All right, good morning, everybody. We'll give a few minutes as everybody makes their way in. Good morning, Dr. Quinn. Good morning, Dr. Bull. How are you today?
Good morning. Doing
Good
great.
morning.
Yay, we're so excited to kick off day two. I know that people are still making their way in, but I'll get started so that I know you guys have a lot of information to present. So, first of all, welcome back to the Ocular Emergencies Summit from Wu University. This is our second day. I'm your host, Dr. Jennifer Stewart.
Thank you so much for having us.
Oh, thank you guys for being here. I'm excited. I love when there's two presenters. It's super fun. It's
Yeah.
a good conversation. So, just some housekeeping for each hour of CE, attendees must be online for a minimum of 50 minutes. There are two presentations today. They're both 2 hours long. So, you do have to be here for an hour and 40 minutes for each presentation. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with your OE tracker numbers. We will display the QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks. And make sure you ask questions using the Zoom on-screen floating panels. My reminder yesterday was this is a long webinar, so don't think you're going to remember your question at the end. Feel free to put those in the chat and Q&A. We may be able to get to them since there's two presenters. They may be able to get to them while they're presenting, but we will certainly leave time for questions at the end. And here's where you can find those if you're tuning in on your phone. So first, it's my great pleasure to introduce once again Dr. Jessalyn Quint. She's a Texas native and graduated from Baylor University with a Bachelor of Arts degree in biology. She completed Master in Business Administration and Master of Science in Biology degrees at West Texas A&M University. She received a Doctorate of Optometry degree from Indiana University. After graduation, she completed a postdoctoral residency in ocular disease with an emphasis on ocular emergency and trauma at the Illinois Eye Institute in Chicago. She's a fellow of the American Academy of Optometry and a board certified diplomate of the American Board of Optometry. She's currently president of the Maine Optometric Association. She practices in Maine, where she co-owns Smart Eye Care and Smart Dry Eye Center. She enjoys providing comprehensive family eye care to her patients with a distinct interest in specialty contact lenses and dry eye disease. Welcome back, Dr. Quinn.
Thank you. It's always an honor to be here. These are my financial disclosures, and I'm so excited to lecture with Lindsay.
Yay. So next up, we have Lindsay Bull. She received her undergraduate degree at the University of Arkansas and her optometric degree at Northeastern State University, Oklahoma College of Optometry in Tahlequah. Did I get it?
Got it.
Good, Oklahoma. She then completed a residency in ocular disease at Eye Care Associates of South Tulsa, where she currently works and is now residency supervisor for the program. She's a fellow of the American Academy of Optometry and serves on the board of the Oklahoma Association of Optometric Physicians as district director. She currently spends her day seeing ocular disease patients and providing laser care, including YAGs, SLTs, and PRK. Welcome, Dr. Bull.
Thank you so much. And thank you again for having me.
All right. Well, and those are Dr. Bull's financial disclosures. And thank you, Dr. Stewart. You do a phenomenal job moderating a lot of the Wu universities, and it's you do great intro. So thank you so much.
Thank
So,
you.
Thank
so
you to everybody
Lindsay,
joining us this morning. We're excited to be here with
yes.
you on this Sunday morning.
Absolutely. Here in Maine, it is rainy, like a lot of the East Coast. So hopefully this is a good, you're curling up with like a cup of coffee or, some fluids to just stay nice and hydrated throughout this beautiful Sunday day. So
Here in
Lindsay,
Oklahoma, it's the first sunny day that we've had in a while. So
it's
it's
good.
been raining here. I think we had 8 inches of rain last weekend. So it's just been raining a little bit.
Yeah, it's good. So we're going to talk all about emergencies. And before we jump in, kind of I think getting in the landscape of what classifies as an emergency. And I feel like Lindsay, when we talk, to a lot of our colleagues, some of us might have slightly different kind of definitions of how we would triage things or what we would classify as an emergency. And I know that there's sometimes always a real disconnect, but by what we as ECPs define as an emergency and what our patients sometimes define as an emergency. But
Absolutely.
what,
I can't tell you how many times I've had patients call in for emergency cataracts, which is a very interesting way to put that, but maybe not an emergency in our mind, but definitely in the patient's mind.
Absolutely. Or all of a sudden order contact lenses, hasn't had an exam in a number of years and, has to be done right now, right at this moment.
Today. Mhm.
So if you had to kind of overlay like an umbrella, what would you say defines an emergency? Just so we're kind of all on the same page.
I think it's going to vary based on patient situation, but our obvious emergencies, and we're going to talk a lot about this today, are going to be things that come with a sudden vision loss, chemical burns, different types of infections that can cause permanent vision loss. And I think it's a really important thing to note an urgency versus an emergency. Every office is going to be a little bit different, and what you want to see in your office and those timelines might be a little bit different than somebody else. And I think that's okay for certain things. But what we're going to discuss today is really those patients who should be coming in immediately. We should be looking at immediately and taking care of as soon as possible.
Absolutely. I think that we as eye docs, we're so qualified to tackle these, right? Or if it's somehow falls with outside of our scope, we are the most qualified to make that referral when appropriate. And so I want all of us as colleagues to be able to feel confident tackling these situations because we have the training, we have the knowledge, we have the experience to do this. And tackling these ocular emergencies are a really great way for optometry to be integrated into the bigger healthcare model. So it's a great way to build relationships with other healthcare providers in your area. It's a good practice differentiator. And also it's just a good opportunity to showcase how important optometry is in eye care as a whole. And
One of the things
I
that
like
we
that you,
Sorry, one of the things that we've done at our office is really when we're looking, because we're very much a referral center. So when we were looking at how do we establish these referral patterns, one of the places that we went was to primary care doctors and to urgent cares. And we said, please allow us to be a part of your practice model. Please allow us to help you out and to get those referrals sent here because I think it's really, really hard. Patients so often go to urgent cares for these eye type problems. And how many urgent cares actually have slit lamp cameras or slit lamps in and of itself makes it very difficult to diagnose those things when we don't even have the appropriate instrumentation to do that.
absolutely. I know. So I grew up in Texas, as you heard my bio, and then I moved to Maine. And one way that I kind of started to form those relationships is I reached out to urgent cares, was just like, hey, if you have a patient that lands here, and every single like PA, PCP, nurse practitioner that was in those settings were like, thank goodness, because
Yes,
I don't love managing that. So just the fact that I know somebody that I can just send that patient to was just such a blessing. So
yes,
I think that's
absolutely.
a really good point. It's also really important to have a protocol. However your office is going to tackle this, we all have different practice settings, but these are patients that are at some point probably going to have some sort of an emergency, whether it's severe or a more mild case. And so your staff is an extension of you. They fall under your licensure. And so we want to make sure that everybody has clear protocol, everybody knows what's going on so that we don't kind of get into the legal ramifications of it. And
And
then, of course,
might I add a clear written down protocol because we're all trained in this. We've gone through extensive years of school and education around when we should be seeing patients. But ultimately, a lot of times the person that's deciding that is whoever's picking up the phone. And so having those protocols written down so that they have guidelines to go by if they have questions, because sometimes they may be able to come back and find you and ask those questions, but other times you may be in an exam room. And so we need to make sure that our staff is answering those questions appropriately and so that we don't get a patient multiple days later that should have been a same day appointment.
absolutely. And then document everything and train on documenting because if you didn't document it, it didn't happen. Even if it's documenting that you offered somebody who had an acute flashes and floaters, a same day appointment, and if that patient denied it, you know, ultimately the patient gets to be in charge of their own body and their own eyes, but you need to document that you at least kind of offer that to them. And I know with my staff, it's, we do really well for a little while. And then like every 3 months, I feel like we have to have a retraining and just getting everybody on the same page for even my super experienced, technicians and office staff. So it is good to put that protocol into writing. And I think too, remembering this on call, do you do on call, Lindsay, with your
We do.
practice?
We
Yeah.
do. Mhm.
And I know a lot of practices, physician burnout's a real thing. And so sometimes it's hard to be everything to everyone and depending on your practice modality and size and whatnot. But I would encourage you to, if you take insurance, read the insurance panels because even something like IMED, right, which is, kind of a vision benefit manager plan in the physician manual, it requires you to offer 24-hour triaging. So you don't want to get into those nitty gritties. Read the physician manuals, read the fine print in your insurance contracts. That if you're not offering those, make sure that you don't kind of get into any legal ramifications with that.
Exactly.
But now let's get to the fun part. Let's get to some cases.
Okay. I think I get to go first. And so this case is a very interesting case. And I think maybe something that might come into your office every once in a while probably is not going to come into your office frequently. So we had this 34-year-old male come to our office, and he reported that about 2 months ago, he was hit by a piece of metal on the inside of the eye. I think it's important to note that his complaint was metal. That's one of the things that we need to have documented in our charts is what we think caused the injury. But since that time, reports that the eye has been really, really painful, really light sensitive. In fact, he's saying about an 8 out of 10 pain severity. Significant vision loss with the eye, which we don't love to hear. He does complain of a mild headache as well, and then some flashes of light that he's been experiencing over the past couple of weeks too. And so I do think it's also important to note that he had no medical insurance, hence the reason that it did take him a while to come into our office because he was concerned at what this was going to cost him. Now, if we look at just his medical history, he had never had an eye exam before. He really hadn't had any type of medical exam before. So he has no illnesses that he knows of. He's not taking any medication, no known drug allergies. And so really we're just starting at ground zero here with this patient. And so I think that it's really interesting because this patient, when the injury happened, said that he knew it was significant. He took himself to the emergency room immediately, and he was told there that he had a possible abrasion, and they gave him instructions to take ibuprofen and use erythromycin ointment 4 times a day. What I think is most important that we can do is make sure when a patient is telling us that they've gotten care somewhere, is we try to retrieve those benefits from wherever so that we can make sure that the patient fully understood what their diagnosis was, that we can understand what their diagnosis was, how it was treated, so that we can make sure that we're following appropriate protocols as well. So we did contact that emergency room. They sent us over the documentation from that day, from that exam. And sure enough, they documented that he had a corneal abrasion. And where I think that we have failed as eye care, or primary eye care providers, as you'll see here on that sheet that we got from the emergency room, that it says to follow up with his primary care provider. So not follow up with an eye doctor, but to follow up with his primary care doctor. And so that's one of the things that I think we as a profession really need to be working on, is that we're making all of these patients, all of our clientele really understand that we are their primary eye care providers, that when we have an emergency go on with their eyes, we want to know about it. We want to see it first, because ultimately that's how they're going to receive the best care. But he was instructed to follow up with a primary provider within 5 to 7 days, which he did not do. And he admitted to that. But he did use the erythromycin ointment 4 times a day, and he was taking the ibuprofen as well. So we take him back for pre-testing, and I will tell you, I was really, really lucky that day. My head technician, who has been in optometry and ophthalmology for over 2 decades, was the one that pulled this patient's chart back, and she was the one that started working up. The way that we've trained all of our technicians is when they're doing their pre-testing, if they come across something that they're uncomfortable with, that they are to come retrieve one of the doctors in the practice so that we can assist with that pre-testing. This is before dilation drops get put in. If they're uncomfortable testing pupils, we know how important pupils are to the neurological system. We want to make sure that the technicians are coming and getting us so that we can evaluate all of that. Now, with that all being said, this technician had been in eye care for over 20 years. And so when she came to my office and said, Dr. Bull, can you help me test pupils? And then she followed it up by saying, I can't find his. That got me out of my chair pretty quickly, because what do you mean we can't find his pupil? Where did his pupil go? Why is it missing? What is going on with this patient's eye? So we went into that exam room, and this is what we saw. And you can see that, like my technician, you probably can't find a pupil in this photo either. I know that I couldn't. What you really can't tell from this two-dimensional photo is how three-dimensional that iris looked. You can kind of see how it's being pulled into that corneal scar, and it was trapped or incarcerated within that corneal scar. So at this point, we know we have a problem, and we know we've had a problem for probably the past 2 months that this patient did not get appropriate care for this eye. And so how do we manage? What do we need to do? What do we need to rule out for this patient? And so, differentials, one of the things that we have to consider is that when we have a significant corneal scar like that, especially with the iris entrapped in it, that typically means that we had some kind of full penetrating injury through the cornea, because otherwise, how would that iris get within that corneal tissue? And so that's the first thing that I know, is that this probably wasn't an abrasion when he first went to the emergency room. It was probably a full thickness injury when he went to the emergency room that was unfortunately missed. Now, the thing that we probably need to rule out is, if you go back to his chief complaint, we remember that he says that he was hit by a metallic foreign body. And so, is there something still inside the eye that has been there now simmering for 2 months that we need to consider and we need to get removed from the eye? And what would those next steps look like for ruling that out? And so we did some examination. Now, the patient said when we had light in front of him that he could maybe see some light. I don't really know how he could see light in there. Typically, you need a pupil to be able to see light, but he said that was light perception barely. We didn't love what his pressure was that day, just about a 3. That tells me that the eye's probably not doing super well. If we're not having that aqueous production there, we're not having that ability for the aqueous to filter through like it should. Anterior segment findings, you can see how red and hyperemic the eye was. We can see this neovascularization going through the cornea. He did have a mild amount of anterior chamber reaction, but nothing that looked significant or infectious to me. Posterior segment, obviously, we're not going to be able to get a great view of the posterior segment just under the slit lamp. So we were able to let me go back. When was this an emergency? Well, this was probably an emergency 2 months ago. And unfortunately, in his case, he knew it was an emergency. He took himself to who he thought was going to be able to best treat and best care for him. But again, we need to figure out if this was a full penetrating injury and if there's something still in the eye. And if there is, how do we rule that out? And so we knew immediately that we were going to need to do some imaging of the eye. Now, when we start thinking about imaging CT versus MRI, we really don't want to use an MRI with a suspected metallic foreign body. And so we were going to send him to the emergency room to get a CT scan done. We did have a B scan in our office as well. And so we were going to do that before he went to the emergency room. And this is what our B scan looks like. And so I was happy to note that I really didn't see a retinal detachment in there. It doesn't look like there's any infection going on there, but you can see how the light is just scattering just very interestingly through the lens. That made us scratch our head a little bit. Why is there so much scatter through in this? What we didn't find at that time was we didn't find an intraocular foreign body. Now, I will say this patient wasn't super compliant when we were doing his B scan. He was in quite a bit of pain. And so he wasn't super happy that we were doing this. I was still suspicious that we might have something going on the inside of the eye. And so we said we need to get a CT scan regardless. And so this is the results of his CT, and I'm going to play it for you. I've got the right eye and the left eye documented there. And again, we're looking at the right eye for this patient. So as I play this, I just kind of want you to keep your focus on that right eye. And what you're going to see here, hopefully, is a nice metallic foreign body just positioned right within that right eye. So I'm going to play it for you all again, just in case you missed it. But that piece coming up right, is everyone else's freezing? Mine's freezing. Let's see if we can fast forward. There we go, playing again. You can see that it's going to pop up right there. Highlights pretty darn well too. And so at this point, we have ruled now in that he had a full penetrating injury of a metallic foreign body that's been on the inside of the eye and just hanging out there for about the past 2 months. This is definitely something that's been emergent for a while. So my slideshow is not letting me go to that next slide. Jesselyn, do you have the ability? There we go. So this is the report back that we got from the radiologist. And what they noted was a 5x3 ovoid metallic foreign body within that anterior superior aspect of the vitreous chamber. What I do think it's important to note is they also said the right ocular lens has probably been disrupted. So if you think about the pathway of this foreign body, went through the cornea, really went through the pupil, probably through the lens, helped to shatter the lens a little bit too. So now we start thinking about all of the things that need to be done to potentially allow this eye to recover to the best of its ability. And I lost control of the PowerPoint slides here. So Jesselyn, I'm going to have you continue to advance if you don't mind. All right, so now what do we need to consider to do? Well, the first thing that we need to consider is what kind of medications topically do we need to have him on? As I mentioned before, he did have a little bit of a low-grade anterior chamber inflammation. And so I put him on prednisolone 4 times a day. We were also going to have the people that we were referring to decide what post-surgical wise they wanted to have him on. I did not put him on an antibiotic at that because I said it did not appear to be a risk of infection, or there was not infection present at that time. One of the things that we need to consider is ptysis bulbi risk, 5.5% after an open globe injury, with that percentage really being on the higher end for people who don't get treated readily or really soon after their injury. With this now being post 2 months after the injury, his risk is going to be a little bit higher than the average person. We also have to consider sympathetic ophthalmia risk, up to 1% of patients following a trauma, which is higher post-trauma than it is post-surgery. Again, he really fits all of these characteristics for all of these things that may be further complications with what he's got going on here. All right, I'll have you go to the next slide. And so referrals, we were going to have to end up referring him to a lot of different places because he had so many things that were really going to be involved with this. And the one thing that I think is important to remember is that he has no medical insurance. So he was already quite panicked about the situation on how he was going to get this eye repaired and how he was going to be able to pay for it. Now, about an hour and 45 minutes from where I am in Tulsa, we have a hospital that has a big ophthalmology residency program, and they do take patients who don't have insurance. And so what we determined at that point was, okay, they're going to have multiple specialties there. I think this is going to be the best fit for this type of patient. And so what we were thinking about at that point is that we're going to have this intraocular foreign body removed. We're going to have all the particles and all of the pieces of the lens removed from the inside of the eye as well. And then potentially what kind of IOL are we going to have to use at that point? And when does that even happen? Is it going to happen at the same time that we remove the metallic foreign body? Probably not. We're not going to get great IOL measurements prior to that. And so is the eye going to have to heal to a certain point before we move on to those next steps? And then looking at that iris, looking at the pupil, how do we establish a pupil for this patient again? And so what type of plastic surgery is involved there with removing that iris from the cornea and allowing that vascular structure to heal as well? And is there And so if we look at, we sent him over there, his postoperative findings, he did present with a hyphema at that 1-day post-op, which we can assume as soon as that iris was removed from the cornea, highly vascularized, it's going to bleed a little bit. He was negative Sidelcine, which was great. His IOP was fairly elevated at about 41, which we would expect with somebody who has a significant hyphema. The meds that they put him on that day, where they put him on a fluoroquinolone eye drop 4 times a day, a steroid twice a day. They put him on bromonidine twice a day as well, and then they did put him on some oral Diamox. At his 1-week post-op, that hyphema was still fairly present, and so they did a B scan that day with the eye being nice and closed from the surgery, and still said no retinal detachment, no sign of infection. So we were really, really lucky in that aspect. That day, they decided to add oral prednisolone as well to help with some of the inflammation and swelling from the surgery. And because that hyphema was really so significant, they said, we're going to see you in a week. And if it still looks that way, we're going to do an anterior chamber washout as well. And so they then saw him a week later, and sure enough, that hyphema was still fairly present. And so they decided, let's go ahead, perform that AC washout, and continued him on the same meds. At his 3-week post-op after that, so almost a month after surgery, patient was reporting hand motion vision, which is better than light perception. And if you look at the visual prognosis score for this patient, that's really where we can expect this patient to lie after having such significant injury. What I do think it's important to note is they did leave him aphakic. And so when they have an IOL in there, will that change his vision? Potentially. He's obviously still going to have significant corneal scarring. And the iris is going to have pretty significant scarring there as well. And so he's still in the surgical process. It's been almost a year since this all started, getting the eye healed, the injury itself, all of that. And so it's been quite a long time, but I really think goes back to the point that we are the physicians that are trained in figuring this out quick as figuring this out soon. Had he come to us day one, would we have found that full penetrating injury a little bit quicker? Most likely we would have. And would we have been able to preserve some of the eye's function? That's hard to say, potentially, but this is one of those things that I think we really need to be getting out in our communities and expressing to our patients who are coming into our office how important it is when they have emergencies to be seeking our care first.
Absolutely. One question that came in, and then I know you'll talk a little bit more about it, was with IOP. So early on, like at the first encounter that you saw him, I think you said that eye pressure was 3. And so the question was, sometimes we've been trained to do we take IOP when we suspect a foreign body? What do you do NCT? Do you do eye care? Do you do Goldman? What do you do? How do you tackle those situations?
I think that's a great question, and I'm going to be getting into that a lot more in a couple of cases here. So I'm glad that question's coming in. What our technicians typically do at our office is that they will take pressure. Those who have been in the field for a while will even do Goldman pressure, but we have eye cares around, but they will not take it on any trauma patient. So patients who are coming in, who are just in for their comprehensive exams, their annual diabetic exams, their IOP checks for glaucoma, those patients that we allow our technicians to take those pressures. For patients who come in with any type of injury, with any type of suspected foreign body, with any really type of infection as well, we tell them do not take pressure. The doctor is going to be the one to determine whether that patient is safe to have their pressure taken or not. And one of the things that we're always looking for, obviously, is a Seidel sign. So if the patient is positive Seidel sign, we are not taking pressure on those patients. We are using a shield, a vaulted shield over the surface of the eye to make sure that nothing is putting pressure on that eye until that eye is sealed.
Great. One other question. Somebody wanted to know how this patient got the metal in the eye.
So he said it was at his job. It was at his workplace. He was using some kind of machinery, and a piece of metal came off that piece of machinery and landed in the eye. Now, he reports that he was wearing safety glasses. I don't know that I believe that, but I do have a lot of patients who, even despite wearing safety glasses, whatever instrumentation that they're using, the safety glasses get blown off their face. I've even seen some pieces of metal get stuck in people's eyebrows, and then they get home at night, they take a shower, and it falls into the inside of the eye. And so, we just go off of what the patient says. We believe what the patient says. He reports that he was wearing safety glasses. If he wasn't, he now knows that he will in the future. But I think that's an important thing too. And so going over I think it's the last slide for this patient, factors that are going to influence kind of what his prognosis looks like. Obviously, the size of the foreign body is going to matter. His was fairly big. If you really compare that to things just that we see on an everyday, think of like your typical pink pencil eraser that's on the top of a pencil. That was about the size of what his foreign body was. So fairly significantly sized to be settling in there for 2 months. Foreign body location is also going to be impactful as well. So this went through his cornea. The cornea is part of, our visual access. And so any scarring there is going to cause some kind of decrease in vision. Vegetative material versus metallic material versus magnetic material versus glass material. I'll say I don't want any of them inside my eyeball, but if I had to pick the worst one, it's probably going to be vegetative matter, because then you're looking at fungal infections as well. Metallic foreign bodies, obviously not great either, especially in this patient's case. Inflammatory response, who knows what his inflammation looked like in those prior 2 months before I saw him. Do I think that it was probably more inflamed right after the injury happened, and then the eye just kind of settled down? Also not great as far as visual prognosis, but the more inflammation there, the less likely we are to preserve a lot of the vision there. time since the injury. When we have a full thickness injury, we want that patient treated ideally in under 24 hours. We were significantly past that time with this patient. He got really lucky. Don't know how he got so lucky that he did not have an endophthalmitis, but there was no endophthalmitis present. There was not a retinal detachment patient or present. So as long as, as far as his injury, not great, but he did luck out in a couple of those categories there.
Man, that's a great case with a
All
lot of
right.
like.
Any other questions on that patient? It was a strange case, and like I said, my technician came back and she was like, I don't know what's going on, but I can tell you it's not good. I was like, you are absolutely right about that.
Yeah, and I love it when your most seasoned tech writer or person in your office is like, I don't know where the people is. That's when you know you're going to be in for a real treat,
And
probably.
I hope that's the only time that she ever comes and says that to me. I would prefer that all of my patients have pupils from here on out.
Absolutely, absolutely. It's a good case. All right, let's rock on to our next case, case number two. So this was my patient, 56-year-old, came in with a complaint or called in actually to our office and said, my right eye is hurting. My staff that took the phone call was like, when did it start? He was like, yeah, it started maybe 1 to 2 weeks ago. I think I might have scratched it after trying to get my contact lenses out, but my lenses are out. And so my staff who was asking other questions like, what's your pain scale? 2 out of 10. So not, a little bit irritated, but nothing too crazy. He did say that he did have some light sensitivity, did have some blurry vision, did have some watering. And so when I think about this case and thinking back to triage and protocol, and I'm a practice owner too, so I feel like when I look at cases, I have one hat, my clinical hat on how I'm going to tackle this, and then two, I have my other hat on as how I'm going to, like, from a team dynamic, right? Like make sure that we're triaging this and make sure that we're tackling this in the most appropriate way. And do I need to change our protocol or our office system so that the patients get the best care that they need? And so when I think about this case too, and I'd be curious for you guys that are out here in the audience and even you, Lindsay, when your staff takes this call, right? And we're trying to decide, when do we get this patient in? Well, if you have a really empty day, that's really easy, right? You just have them come on in. But if we think on one hand, he does have a fairly acute kind of pain, but the pain scale is 2 out of 10. So not super bothersome, isn't reporting any vision changes, but he also wears contact lenses. And so some of us might be split on this. And so some of us might be saying, all right, well, since he wears contact lenses and this is, has any pain, like let's get him in like right away within 24 hours. And then there might be some of us out there that are like, it just started 1 to 2 weeks ago. I have a cram full day. We'll just get him in within like the next few days and kind of go from there. So think about how you would do it. And then as this case kind of plays out, see if, in hindsight, we would do anything differently. So this was a day where it was a crazy day and I didn't have any space. And this was also like the fourth or fifth patient that had called in with this complaint. But
Of
at this
course.
point, I was just, yeah, that's how it always goes, right? In themes. So at this point, my staff came to me and I was like, just tell them to come in. Like, we're here probably till, the end of closing hour and we're just going to work him in essentially. So I did end up seeing him that same day. So medical history had anxiety, depression, hypertension, neuropathy of the feet, was on medication for those, no known allergies. Ocular history had a eye exam 5 years prior, still wearing monthly multifocal contact lenses, which is always just like, why, right? Like, how is this happening? Where are you getting these lenses? It's been 5 years. How are you still wearing them? But different day for a different story. Social history, unremarkable. Entrance testing, hand motion at 4 feet, not improving pinhole, left eye 20/30. So I remember when I saw his vision, on one hand, I was like, did we check that correctly? Because of the fact that when he called in, he didn't have any vision complaints, right? Like he was like, yeah, it's fine. Pupils looked unremarkable, confrontation, grossly okay. EOMs full, eye care 17 in the right eye, 16 in the left eye. So put stain in, at this point, I was with the patient. I went, looking at him behind the slit lamp. That right eye had about 3+ injections. It was pretty red and pretty irritated. Both eyes still had the contact lenses in it. The iris looked pretty normal. I could see that he had early cataracts. I could see that even on that right eye that the cornea, like some funky stuff was happening. Like it looked pretty edematous. It didn't look great, but I didn't at the first sight didn't take too much of an index of it because I was just like, we just got to get these contacts out. So I popped back out, took out the contact lenses, put in fluorescein, went back behind the slit lamp. And I had said this was like the fourth or fifth one for the day. So I got back behind the slit lamp and I'm looking at his right eye and there's a contact lens in the eye. And I remember thinking, like, I took that out, correct? But you know how, like, when you have a busy day, you start kind of like second guessing yourself because you just are like, did I already say that? Did I not say that? Did I already do this? Did I not do this? And so I was like, oh, weird. I must have just, forgotten to take this eye out. So popped back out, took the contact lens out, went back behind the slit lamp and I'm looking at it and there's another contact lens there. And so in this case, I was like, all right, so I'm not crazy. This is like this, these are multiple contact lenses. And so I ended up like fishing two from the trash can and put them all out so we could see it. So in the right eye, ended up pulling out 5 contact lenses out of his right eye. And you can see that top one that has the fluorescein. That was the second one from when I put the strip in. Now, why he ended up with 5 contact lenses in the right eye and only 1 contact lens in the left eye, I'm not entirely sure. But at this point, I was like, I have questions, sir. I have questions. Did what happened? How did you get these out? Because if you remember when he called back in, he was trying to remove his contact lenses and he thought that he had scratched it. And that's kind of what had started this whole, kind of office visit sort of situation. So I was asking him, like, we have these contact lenses. What happened? Tell me a little bit more about the story just to try to deep dive. And the story is that once a year he would have a really big cry. He thought that he cried out the contact lenses and then he'd like regain his composure, pop in a fresh set for the year, and then continue on his life, his journey, which makes sense because he had an eye exam 5 years prior. So how we managed to get them out of the left eye but not the right eye, I'm not entirely sure. But lots of contact lenses in the eye. So when they were out, then, and of course, this was on a day where none of my technology was working. These are photos with my cell phone, my anterior camera was down, and it's just this all happens usually when you're at the busiest and when you need it the most, essentially. But we can see that this cornea is not looking too hot. So we've got this pretty large central epithelial defect, kind of kind of a hazy cornea. We've got lots of neovascularization. This is also central, right? And he is not probably the most compliant patient. And when we see a cornea like this and we think back to his pain scale, 2 out of 10 severity, definitely, we've got some things to consider as far as a diagnosis. I always think it's important to still peek out the back part of the eye, even if you're thinking it's going to be an anterior seg case, especially for emergency patients, because you never know. There could be a bigger fire behind there that you need to put out. And especially for this guy where he hadn't had an eye exam in 5 years and vision is not great. Luckily, he just had some cataracts. Nothing else in the back part of the eye was that remarkable. So at this point, thinking about, what is this diagnosis? How are we going to tackle this case? Am I going to tackle it? Am I going to refer it out? What does that look like? So I really try to manage everything that I can within my office, and especially in Maine, we don't have access to a lot of corneal specialists. Sometimes it takes time that, patients have to travel hours and hours to get to this kind of care. So I really do think it's important to just try to tackle it as best as I can. So differentials that were running through my mind, I mean, maybe this is a corneal abrasion that's been sitting for a little bit, or maybe like a corneal ulcer. He wears contact lenses. He's clearly over wearing them. That cornea didn't look too great. So maybe we've got some sort of, kind of nasty organism that's, behind the scenes there. Or maybe this is also kind of a neurotrophic keratitis, ulcer kind of case, right? Especially he has a history of neuropathy. His pain scale was 2 out of 10. He's not sensing that cornea should feel as bad as it looks. And so, what is this, right? And so how do we tackle it? And any of these really could be a possible diagnosis. When we think back to if it is something that is kind of infectious, right? Or if it is going to be like a corneal ulcer from contact lens overwear, if we think back to just looking at corneal lesions in general, and if they're sterile, meaning more inflammatory, or if they're infections, you know, things that are more infectious usually will be a little bit more larger. They'll usually fall a little bit more central. You might get some mucopurulent discharge. Usually with infectious, you'll get more of like an anterior chamber reaction or lid involvement. You'll definitely have more pain and light sensitivity. If it was something that was just sterile or kind of inflammatory, these would be much smaller lesions, very minimal epithelial damage. Typically, those tend to fall more peripheral. They don't tend to have any lid involvement or any kind of anterior chamber reaction. If you do suspect something that is infectious, and I love this good reminder, is that if you have a contact lens patient, you really have to treat it as infectious until proven otherwise, even if those lesions look really, you know, kind of inflammatory based. But if it is infections, we're really just thinking about like what pathogen we're dealing with, because if we're going to treat it, our treatment plan is going to be, you know, dependent on what sort of pathogen we're trying to eliminate. So in general, you know, pathogens could be viral, they could be bacterial, especially with contact lens. Pseudomonas is a big one. Could be fungal, something vegetative, or it could be our lovely, you know, acanthamoeba friend. And so in a perfect world, you know, culturing would be something that we would want to do. When we talk about these non-infectious infiltrates or those sterols, those are things like Claire or CLPU, or just kind of those marginal corneal infiltrates that are there. So with culturing, you know, when do you culture? So I tend to try to culture if it's large, if it's central, if the patient just isn't responding to treatment, if they're post-surgical, if they're monocular, if they're very immunocompromised, or the 3-2-1 guide, which is if you have a corneal lesion that's more than 3 millimeters in size, two or more ulcers, or if it's falling within 1 millimeter of that visual axis, pretty, you know, that's a pretty good kind of rule of thumb to follow of when to culture. Ideally, you want to culture before you initiate any treatment. But, you know, sometimes it's, and especially in my area post-COVID, it's just a different world of being able to culture. Some of you, if you see these quite frequently, you'll probably have these quick culture or plates possibly in your office. But if you don't see these a ton, you know, with my business owner hat on, then sometimes the ROI to carry these financially doesn't quite match. And so then if you're not going to carry an office, you just need to know how to send your patient or how to kind of get them access to culturing if needed. In my neck of the woods, post-COVID, sometimes it's really tough and it doesn't happen immediate. And so often I'm faced with kind of the decision making of, you know, do I delay treatment in order to get the culture, or do I just go ahead and start? And so sometimes now I'm just having to start treatment, and I make the best judgment that I can. And then if things aren't responding quite how I would like, then obviously, you know, then we'll kind of backtrack from there. But when we do have treatment and we do figure out exactly what organism we're dealing with, and obviously we're going to create our treatment plan that reflects that. And so quick reminder of, we have a lot of different antibiotics in our toolbox. And so remembering like which ones are broad spectrum, which ones are better at gram positive versus gram negative or MRSA, all of those, you know, tools and knowledge bits that we've learned in the past, make sure you hold on to that so that when these cases present, you know, the best drop or medication to recommend to your patients. Sometimes too, steroids will be appropriate. I know sometimes when we have a damaged cornea, there's kind of this belief that, you know, we might want to delay treatment of a steroid initially until things start to improve. But sometimes you have to almost lead with a steroid in some cases to kind of get that inflammation down. So of course it's going to be a little bit case dependent. And then one of my favorite treatments for any sort of corneal damage or pathology in general is an amniotic membrane. And so amniotic membranes, as a quick reminder, they're derived from the innermost layer of the human placenta. They kind of act as like a superfood. So they have all these different structural proteins, these growth factors, these cytokines that really just help promote faster healing, less scarring, less inflammation. They're not new. If we look back to how they've been used, Currently, there's over 700 peer-reviewed publications on specifically the ocular use. But the first cases are in the early 1900s, and then we're starting to see the use of amniotic membranes in a lot of different other healthcare professions. So in dentistry, they're using it for gum disease, obviously in diabetic care for different wound healing or burn victims. In sports medicine, they're using it for some soft tissue injuries. So lots of different uses, but especially within eye care, we have a lot of different options for this. So in general, if you have any sort of ocular pathology, or in my case, if you're thinking about, is this a corneal ulcer, or is this, a scratch, or is this a neurotrophic kind of keratitis issue, amniotic membranes can check a lot of those boxes just because of the broad scope of what they can do from a healing perspective. There's lots of different options, and they all have different pros and cons. Broad categories for amniotic membranes is there's cryopreserved and then there's dehydrated, and it just has to do with the way in which that tissue is harvested. So cryopreserved, that tissue is slowly frozen, and there's a couple different versions. There's the type where it's frozen and it's held in place by a plastic ring. Those are like our Procaras, where they have Procera, Procera Slim, Procera Plus, which is like the double-sided one. That company also now came out with the CAM 360, which is that cryopreserved tissue, but it's stored at a shelf life. You don't have to keep it frozen, and it's held in place by a collagen shield. And then there's the dehydrated, and there's lots of different companies that use this. And it's, that tissue is slowly dehydrated essentially, and it's stored at room temperature. And when you put it on the eye, instead of having a plastic ring, it's held in place by a soft contact lens. So there's different schools of thought on which of one of these is the most effective. I feel like in everyday practice, they both serve a purpose. And so I'll reach for one more than the other, depending on certain cases and different types of pathologies that I see. Lipofuscized amniotic membranes is newer to the US, and it is here. It has to do with essentially kind of like freeze drying, how that tissue membrane happens. Not a lot of US data. Most of the data right now is in European studies, but this is new. So more to come as we see this play out. But those are kind of overviews of just infectious, but if you are thinking about neurotrophic keratitis, it's really helpful to remember to test corneal sensitivity, because if you're not sure, if you can get kind of a test of how sensitive the cornea is, that can be really telling. And if there's a lot of different ways you can test it, but if you do test it, and if the sensitivity is absent in any of the quadrants, then that's pretty indicative of something that's more neurotrophic. So there's lots of different ways that you can test it. Bonet's, the aesthesiometer. Some of us might use a cotton wisp or unflavored dental floss, or now we have the Brill device, right, that is a handheld, or you can mount on a slit lamp. But whenever you check it, if you're checking in an office, I always say, like, check it in 5 places: superior, temporal, inferior, nasal, and then central, and just document like the presence or absence of it. I document all 5 because sometimes, most of your cornea might be pretty good, but there might be a little section that is, doesn't have full sensitivity. And so if you didn't check that, then it could give kind of a false representation of what's happening. The other thing I would say is when you're checking it, because a patient can see you when they're coming in. And so sometimes visually they see you move and they'll say yes, that they feel it. So you really have to maybe check it in a couple places and make sure that when they're responding yes, they feel it, it's because they're actually feeling or not feeling it, rather than looking for the visual cue of your hand kind of moving in to test for it. That's where like the Brill device is really good at kind of teasing some of that out. So neurotrophic keratitis, this is that mnemonic stain without pain. And this is where the patient doesn't have any symptoms, but clinically we see a lot going on. Usually neurotrophic keratitis is going to have some sort of an underlying risk factor, whether it's an infection, injury, inflammation, if they are diabetic, if they have neuropathy, like so many different things, and that can be kind of a clue of what's happening. And then remember that neurotrophic keratitis, because it doesn't always cause a lot of those symptoms. A lot of times that disease progression will go very much unnoticed, because those nerves are not picking up and sending the message to the brain for the patient to detect it. There's the different stages, early on, it can almost just look like dry eye where we get those general epithelial alterations or those persistent epithelial defects. But when we start to get to stage 3 is when we start to see the ulcer. And then obviously if that progressed, then that could end up in something like a perforation. Whenever you do treat NK, amniotic membranes, as we talked about, is a really good option. There's also topical insulin, Synedgerman, which is oxyrvate. There's different surgical management or kind of a matrix therapy agent. So for just NK, we have some different options there. If you do, just kind of a reminder, if you do Synedgerman, this neurotrophic keratitis is still considered rare, so there's a good chance that you can help get great coverage for your patient by doing this. You can prescribe this through e-prescribe, but you can also fill out this form, the oxyrvate form, which you can pull off the website, and the patient has to sign it. So if I'm even going to maybe recommend this to a patient, I'll have them sign it while they're in the office, fax it in, and kind of see if we get coverage for that. Synedgerman or oxyrvate was FDA approved back in 2018. It's a biologic. It has this recombinant nerve growth factor, and it basically can help repair those nerves, which is awesome. It's dosed 6 times a day, so every 2 hours for 8 weeks. It's a little bit different than kind of a normal drop. So a normal drop, we send it into the pharmacy. It comes in a little bottle. When a patient is using oxyrvate for neurotrophic keratitis, they, over those 8 weeks, each week will have to kind of mix it up themselves. So they'll get this little kit that has like 7 vials of oxyrvate, 7 of little adapters, 42 pipettes. And then if you can see in this photo, this is how they will instill the drop. So it's usually through a little pipette like this rather than the bottle. It works awesome. It does feel a little bit of an intense 8 weeks, but to be able to actually heal those nerves is pretty remarkable for kind of a long-term strategy. So quick background to get us to basically of how I manage this case essentially. So this, 56-year-old, we have a couple of differentials. Is this a corneal ulcer from something that is a pathogen, or is it neurotrophic keratitis? And honestly, it could kind of go either way, but I was really possibly leaning more a little bit to the neurotrophic keratitis just because of the lack in pain scale. But to cover it, so I decided I was going to roll with a cryopreserved membrane. In this case, I did a Procera Slim. We did ciprofloxacin every 30 minutes. My tech had cycloplegia. We didn't need to cycloplegia, but I think we were just on a busy day and it was like pain management. We had done this for 4 of the other patients previously. But in hindsight, we didn't need to do that. And I put this membrane in and I had the patient come back 1 day later. I did ciprofloxacin because it's a broad spectrum and it's always available at my pharmacy. I don't usually love doing this when I'm doing something like a Procera because a ciprofloxacin, especially generic, will have a lot of precipitates that will stick to the membrane, and so it can make the cornea look very white and opaque when it can be a little bit scary when the patient comes back in. But I knew that I wanted to get some sort of coverage on this eye as quickly as possible. And anything that wasn't that, my pharmacy was probably going to have to order. And I did every 30 minutes because I was hoping that he would at least get it in every couple of hours. For a different patient, I probably would have dosed it every kind of 1 to 2 hour rather than every 30 minutes. Had the patient came back, so not even 24 hours later, he was back in, and most of that membrane had pretty much been dissolved. And so if you've worked with these membranes before, the faster they dissolve, essentially, the more disease cornea is that you're starting with. There's no global period for these. So if you truly have a medical necessity, you could pop back in, pop a new one in the next day, which is what we did. So I replaced it, put in a new Procera Slim, kept him on the same topical antibiotic, had him come back the next day, but kept it in place. And then when we got to kind of 4 days out, that second membrane had pretty much dissolved, but the cornea was looking a lot better. So had kind of 2+ SPK, but that infiltrate or, the corneal ulcer that was pretty large was essentially resolved for the most part. So at that point, his eye was still pretty red though. So I started taper the antibiotic a little bit to just 4 times a day, started at 1% pred acetate every couple of hours, and then recommended copious preservative-free tears because we know tissue always heals better when it's hydrated. Had him come back 2 days later. So at 6 days out from initial presentation, the SPK was a little bit better from being on that topical steroid. So at that point in time, we stopped it, or we stopped the antibiotic, we decreased the pred acetate, and then still continued him to use the copious preservative-free tears. Had him come back a few days later. When we got to the 10-day mark, just a little bit of SPK. Vision was 20/25, which is pretty remarkable from going from hand motion to 20/25. Now, also, if we think about how many contact lenses were in his eye, 5 contact lenses, and he was like a -5. So it's possible that that hand motion might have, a big chunk of been from all of these, contact lenses of -5 power in the eye. But pressure was stable. He did have a small central epithelial scar. So, that kind of explains why he's not a perfect 20/20. But within 10 days from where we started to where we ended up is pretty remarkable. And so when he has came back, so I didn't initially check corneal sensitivity at that visit because there was just a lot of stuff going on, and I didn't want to risk adding anything else to that cornea if I could. But when he came back, and then after this, we scheduled him for a full exam. And at his full exam, where of course he wanted more contact lenses, we did check corneal sensitivity, and it was definitely decreased. So since then, we have done a round of Oxervate on him, and he's having a lot of improvement, and things, are a lot better. And he's much more compliant with his contact lenses after a lot of education with that. So, but when I look back at this case and I think about the clinical pearls from it, really teasing out, I needed to pick a tool that would check a lot of boxes. So in this case, like a cryopreserved membrane gave me a little bit of cover if in fact it was neurotrophic keratitis ulcer, or if in fact we had some sort of a pathogen. With contact lenses, you always have to assume it's infectious until proven otherwise. So a broad spectrum antibiotic will get you coverage. Don't forget to culture if you need to, and if you have access to that, that is always a really great way to tackle patient care. I think we have
There's a couple of things that I really love with this case too. When you talked about what type of amniotic membrane to use, I think the cryopreserve, specifically the Procera, not the CAM 360, on anything that has an infectious etiology or potential infectious etiology, not using a membrane that has a bandage contact lens on it, I think is important because you want to try to prevent that hypoxia that could cause that infection to slow or delay healing. And then, there's a lot of studies that have come out recently that the use of amniotic membranes is actually regenerating those corneal nerves and neurotrophic keratitis as well. And so you were covering both bases by using that Procera Slim for the neurotrophic keratitis. And if there was an infectious etiology, I really think that you did a beautiful job with that case.
Thanks. And if you haven't used Procaras, they do like 1-day shipping. So if you haven't used this and you know that this is going to be the perfect tool, like reach out, you can quickly get these for your patients. And it's, even if you buy a couple, they don't expire for a while. And I feel like there are so many uses. I remember when I was first kind of starting to use them, I was like, I don't know, I might only use this once or twice a year. And I'm amazed now at how frequently, just in a primary eye care setting, the need for these, the use for these pops up. So if you haven't quite, kind of dabbled in essentially like embrace it, try it. It's a great tool for your patients.
Yeah.
Lindsay, do you culture in your office?
We do culture in our office, and we're culturing quite a bit frequently. And, one of the things that I think frustrates me about culturing sometimes is you'll have an ulcer that is infectious. You culture it, you feel like you get a really, really good specimen that you send off, and then your report comes back that it didn't have any growth. And you're like, that is such a lie. I know something is there. Just because it comes back, if it doesn't have growth, that I don't think I'm ruling out that there's an infectious etiology there. I'm still treating it as if it were. But the great thing when you do get back some growth is that they will take it a step further and they will test it against different antibiotics and tell you which antibiotics, whatever's growing on the plate, is responding to best versus which it's resistant to. So you can change your treatment pathway based on what those culture results are as well.
I love that. We have a question. I'll let you answer because you do more culturing than I do
Okay.
in office. Question is, to obtain a culture, do we wet a cotton swab and roll it over the lesion, or do we have a specialized container to place the inoculated cotton swab in before sending it to a lab or corneal specialist?
Yes. So you're not going to use just the average cotton swab that you have in your office. You're actually going to get a culturing kit. Typically comes in almost like a tube with this very specialized cotton tip on the end of it. So that's what you're going to use. It comes in a sterile device. Now, the trick with it is, and I wish I had a pencil or a pen to show you, is these swabs that they send in these kits are fairly long. What you want to make sure that you're doing is only holding the outside aspect of it, that you're not touching the actual stick where the cotton swab is on, because then ultimately you're introducing the ability for bacteria that are on your hands or on your skin to be cultured within that swab test too. So it can be a little difficult because you've got this long stick and now you're just kind of dangling it around the eye and trying to debride that off. If that's difficult, even taking a sterile instrument and scraping some of it off the cornea and then using the swab to use some of that scraping to then put it in that tube and send that off to your lab.
Awesome. One question, would topical moxifloxacin cause the white precipitates? Any fluoroquinolone can cause the precipitates. It is a little bit less than ciprofloxacin. Ciprofloxacin is like the worst, I feel like, for precipitates. But I can get moxifloxacin, but it usually takes my pharmacies like a day or two, and I didn't want to kind of risk any kind of any delay in that. And then
And
another question.
I'll add a piece on that too, especially because you use an amniotic membrane in this case. You know, a lot of the amniotic membrane reps will come into your office and they'll say, well, when you have an amniotic membrane, because it has antimicrobial properties, you don't have to use an antibiotic. I still always use an antibiotic, but remember with those precipitates, it's going to coat that amniotic membrane as well. So when you bring the patient back, if the amniotic membrane looks like it has a lot of mucus or a lot of goo on it, it could just be the buildup from that from the antibiotic. You can, especially with the Procara Slims, I will even take that off of the eye to evaluate the lesion underneath. And then if it's not completely dissolved, I'll just put that same amniotic membrane back in. If it is completely dissolved, I'll do exactly like you did. I'll just replace it with a brand new one until the defect on the cornea is resolved.
Yep, absolutely. And then another one is, how accessible, affordable is Oxervate for patients? So I would say all but one of my patients, which is like a lot. Maybe I think I've done this maybe at least over 100 patients at this point. Have it's cost them like $0. I had one patient that it was a little bit more, but they financially didn't quite meet the goal, and they could easily kind of cover the cost of that. So the beauty with that though is that when you fill out the form, it goes to like Dompe Cares and then a different pharmacy, and it's the Dompe Cares program that will help make it very affordable for your patients. And it does have to go through insurance, and so sometimes you can get immediate, access and coverage for it within like 2 days, and sometimes it can take like 30 days. Some insurances will only cover it once a lifetime. Some you can do like a repeat treatment if needed. There's a few insurances that say that unless you do a peer-to-peer review, that only an MD or like a corneal specialist can recommend that. We all know, but usually on those cases, when I've done a peer-to-peer review and showcase my knowledge, how I manage it, then it was easy to kind of get access to it. So usually really great coverage and affordability for your patients.
Just make
Um,
sure that you're telling the patient that it does have to go through this process. So patients are very used to being able to go to their pharmacies and getting their medication within the next 24, 48 hours. This may not be that case. And so just make sure when you're having the conversation that you're starting a patient on it, that they're aware that this may take several weeks to get in their hands before they actually can start the treatment.
Yep, absolutely. Another question, if you only had a dehydrated amniotic membrane, would you use it like in this case versus like a Procara or a cryopreserve? In this case, I probably wouldn't. Anything that is very possibly infectious, I just don't put a soft contact lens on the eye. So I would probably pause and not use dehydrated. But I use dehydrated a lot for any sort of like keratitis where I know it's not infectious, where it's purely inflammatory. So if it's really severe, a lot of corneal pathology, I won't just put it on just because of the sake that I have it. I'll wait and try to get access to a cryopreserved. But again, that doesn't mean that there aren't some other uses for dehydrated.
I would the same way. I am not going to use anything that requires a bandage contact lens over anything that's infectious. I think legally you would have a really hard leg to stand on if the case were to go wrong if you put a bandage contact lens over that eye.
Absolutely. Great questions. Keep them coming. But for now, we'll move on to our third case.
All right. So third case, of course, another new patient that I have no baseline examination on. So we're starting from square one here. He arrives as an emergency work-in with the complaint that he was cleaning a tire at his job about an hour ago and it exploded on him. Now, typically, when we read that kind of chief complaint, we know somebody's working with a cleaner. Cleaner equals chemical. If that patient is calling in, we're telling them, hey, hesitate. You need to wash out before you even get in your car and come here. Now, ultimately, we didn't have that option with this patient because he came directly to the office. 10 out of 10 pain, couldn't even open his eyes. So actually had one of his work friends drive him into the office and lead him into our building with his eyes closed. And so he was brought into our office, immediately taken back. And I still don't think I have access. Yep, Jesselyn, you're going to have to continue to click for me. And so he comes in, again, no medical diagnoses. He's never had an eye exam previously, which don't we love that for all of my patients. No medications that he's on, no drug allergies. So again, we're starting from square one with this patient. And so entrance testing, we're able to get some visual acuity on once we numbed the eyes. They were about 20/50 out of that right eye, 2100 out of the left eye. Pupils look normal, visual fields normal, everything looks good. We mentioned this with my last case, and which is why I really loved that last question that came in. The technician did defer taking IOP until the doctor came in to evaluate, because we know when we have any kind of explosion, we're looking for a lot of different things with this case. So how are we going to manage, and really what are our concerns with this case? And because I think that there are quite a bit of different concerns. Number one is what type of cleaner was being used. You know, we know that this is some kind of chemical, and so that we're using some kind of, we might have some kind of chemical injury to the surface of the eye. The patient was not aware of what type of cleaner it was, which makes things a little bit more difficult, because then we might have to look and do some Google research on our end a little bit more of what even common types of chemical cleaners are and what those ingredients look like. Also, what kind of injury are we looking for? With a tire being explosioned, are we looking for foreign bodies? Are we looking for abrasions, lacerations? Again, that chemical burn. So we have a lot of different things that we could be looking at and could potentially be managing for this patient. And how do we rank those in order of importance? And what do we need to be managing first when a patient like this comes into our office? And so, in my opinion, the thing that we need to be concerned for first is going to be that chemical burn. We need to be rinsing it out. And my technician very much was aware of that. She called us in. We do not have any Morgan lenses at our office, but we do have lots of bottles of sterile saline. So we're just going to start rinsing out, and we're going to do that for a while. When we looked back and researched just common types of tire cleaner ingredients, you can see that the pH is really all over the place. So we've got acids, we've got bases, we've got a lot of things that we're dealing with that could potentially impact the pH of the eye and the tissue of the surface of the eye as well. So if you do not have some of these pH strips in your office, this is something that you can very easily get off Amazon for not very expensive. This is actually the exact type that we have. It comes in this roll of paper. You just tear a piece off, and you're going to gently touch that to the tear film in the surface of the eye. And the color that the paper turns is the pH of the eye. So you want your pH to be somewhere between 7 and 7.5. So you're looking at really somewhere between that mild to moderate green color for your pH strip. Once it gets to that color, you know that the pH is normal, and you can document that. I'll even take a picture of the color of the pH strip to include into the patient's chart, just for further documentation, because like Jesselyn mentioned earlier, if it's not documented, you didn't do it. And so I like to have that documentation as well. After the first flush, the patient's pH was within normal limits, so we were able to go on to the next concern, which in my opinion was going to be some kind of foreign body. Do we have some kind of foreign body, potentially corneal, conjunctiva, intraocular? Look at the adnexa as well. Make sure you're looking in the eyebrows to make sure that there's nothing buried within the hair there. Is there something penetrating? Do we have a positive side L sign? And if there is a foreign body, is this something that can be removed in office, or is this going to have to be something removed during surgery like my previous patient? Knowing the type of object that you're working with, I think, is important too, because tires are made of lots of different things. So you're going to be looking for a plethora of different types of objects within this specific patient's eye, whether that be rubber, steel, fabric. We were really happy that we were not able to find any foreign body under the lids anywhere. So we were then able to move on to our third emergent diagnosis, which was going to be those abrasions and lacerations that are present. Now, again, this patient walked in with 10 out of 10. So there's something going on with the eyes there. And so when we're looking for these abrasions, lacerations, we're looking for size, we're looking for location, and then we're considering how do we treat these things? Are the eyes going to be treated equally? Are they going to be treated different? And what do we need to do to make sure that both eyes are healing the way that they're supposed to? And so going on to that next slide, I believe. All right, so I think that this picture is really important because when you compare the right eye to the left eye, upon first glance, you can see that the right eye has multiple different abrasions on it. Remember that the vision out of the right eye, though, is better than the vision out of the left eye. When you look at the left eye, you're not seeing a lot of abrasions or lacerations there. You're seeing just kind of this smooth fluorescein appearance. Where I think this gets really tricky is you have to go off patient symptoms and then really take a very decent look at what that fluorescein is doing. What you can't tell from this photo is that he has no epithelium left on that left eye. And so the fluorescein was actually soaking into the stroma, which was giving it that nice green glow, but could be very easily missed, especially if you're not taking that extra second, because there was no any apparent abrasion there. What we were seeing is more of a chemical injury on the surface of the eye that melted all of that epithelium away, whereas the right eye had more of the abrasion patterns on the surface of the eye. And so looking at those anterior segment findings, the right eye, we measured about 15 small scattered abrasions across the cornea and conjunctiva. That left eye, limbus to limbus corneal epithelial loss, which is obvious more significant, going to take longer to heal. He was already pretty hyperemic and had started to develop a little bit of anterior chamber cell as well. Like Jesselyn mentioned earlier, I think with any type of ocular emergency, it is important to note and document that posterior segment as well, especially when we're considering some kind of blunt force injury. Are we dealing with a retinal detachment? Do we have commotio retinae? Is there some kind of vitreous hemorrhage that we need to be aware of too? We were really lucky once we prepare-caned this patient, he was able to sit for a dilated exam. We documented that. We did not see any evidence of blunt force injury on the inside of the eye. And so how are we going to treat these eyes? We know that the right eye has the lesser of the injuries, although still significant and better vision. The left eye has much more significant of an injury and much poorer vision because of that. So are we going to treat these the same, or are we going to maybe kind of divert and do different things with both eyes? And I think you could really do either way, but our thought process is we love the use of amniotic membranes when we're dealing with significant injury, especially with somebody with limbus to limbus loss of the epithelium. Any type of anti-inflammatory, any type of pro-healing that we can do for the eye, we consider something that we should potentially consider for the eye. Now, the thing that you have to remember about amniotic membranes is it's like putting a piece of wax paper over the eye. So if we do that on both eyes, where are we leaving that patient visually during this healing period? And so what we decided was that that left eye, because so much more of a significant injury, I wanted the amniotic membrane on that eye versus the right eye just using a bandage contact lens and then different medications to allow for that eye to heal as well and still potentially preserve the ability for the patient to be able to function over the next couple of days. And so when you look at amniotic membranes, I know we just talked about them quite significantly, but they do also decrease the risk of recurrent corneal erosion. When somebody who has injury patterns like that, we know that they now have a risk for that happening in their future. So if I can decrease that risk for them, something that I think that we should definitely consider as well. One of the things that I will notice is that cost to the patient. There's one insurance in Oklahoma that actually will not let us recommend an amniotic membrane and apply it on the same day. We have to bring the patient back the next day to put it on, which I know it's very frustrating, but making sure that you're looking into those things for the patients too, because you don't want them to have that gigantic bill versus if you had just brought them in a few hours later, the insurance company would have to be responsible for that cost. And so make sure you're looking into those things. We know small abrasions are going to heal a lot faster than large abrasions, and we know that with limbus to limbus loss, it's going to take a little bit for those stem cells to really start proliferating and growing again. So we're looking up to 2 weeks for that epithelium to resolve on this patient. And so, like I mentioned, right eye, we were just going to bandage contact lens. When I tugged up on his upper lid, he did have a couple of loose strands of epithelium left that we knew were not going to heal back or readhere to that corneal surface. So we did debride those cells off. I just used a Wexel sponge and some sterile forceps to do that. And then we did put a cryopreserved membrane onto that eye as well. And so medications, very similar to what I use for my PRK patients as well. We put them on a fluoroquinolone 4 times a day, a steroid 4 times a day, and NSAID twice a day. I did atropine in the office. We did not call in any atropine for him. We knew he was going to be coming in the next day. We decided we could just atropine him in office to kind of cut that cost for him. In Oklahoma, we have the ability to prescribe Ativan, or lorazepam, and gabapentin as well, which we know that gabapentin does decrease the corneal nerve sensitivity. And so for pain wise, I think that's a really nice way to control pain for these types of patients. The lorazepam also helps with that pain and helps just kind of allow them to sleep and sleep easier for that first 24 hours too. And so we wanted to see him back the next day after that. And so we saw him back the next day, and his vision had actually decreased. And so this might cause some concern, but we have to remember he came in so soon after the injury that the corneal swelling really hadn't been present yet. It didn't have enough time to swell. So I expected him to swell more significantly over the course of that next 24 hours, which he did. And so that was the reason for the decreased vision there. His abrasions had really significantly healed in that right eye, but they weren't completely gone yet. That amniotic membrane, we did remove it just to see if I had any type of growth there. And we were starting to see a couple of millimeters of growth in the periphery of the cornea. So we were really happy with that as well. I then just took that same amniotic membrane and replaced it inside of the eye and said, okay, we'll see you back after the weekend. And so he went home for the weekend and then came back in that following Monday or Tuesday, and vision had improved in that left eye pretty significantly. That right eye, the abrasions were healed, so we discarded the bandage contact lens. The left eye still had about a 2 millimeter defect centrally noted, and so the amniotic membrane had completely absorbed. That ring was the only thing remaining. We removed that. We replaced with the bandage contact lens for continued healing at that point. We also started switching around his drops. I decided we didn't need the antibiotic in the right eye since those abrasions had healed. We were going to continue all of the rest of the meds and then to see back later in that week. And so we saw him at the end of the week. Vision was about 20/80, 2200. Anterior chamber cell looked great. His epithelium was intact in both eyes. And so at this point, we started tapering him off the steroid. I definitely wanted to continue that lubrication significantly to try to prevent that corneal erosion from happening, discontinued the other meds, and then we were going to check him back in 2 to 3 weeks for a vision check. I think it's important to note that he was pinholing to 20/30. So during this entire process, because he was a new patient to us, I didn't know what his refractive error was. He didn't know what his refractive error was. So we didn't really know where our endpoint visually was even going to be with him. The good news for him is that we documented grade 1 chemical burn, which is really just that corneal epithelial loss. And these patients typically will have a really decent prognosis visually. When you start getting into your further grades, that's when you're getting more of your ischemia. That's when you're getting more of your scarring and potentially can have more permanent vision loss with those types of cases. Hence the reason that the chemical burn was the thing that I thought was the most important with this patient, getting these eyes flushed, making sure that we were trying to eliminate that risk of it progressing to a grade 2, 3, or 4 chemical burn for either of these patients' eyes. Prognosis, as far as the corneal foreign body, again, when we're looking at these, we're really looking at depth, what that material looks like, where the location of it is. Same with the corneal abrasions, the depth and location. Are these things going to scar? He was very, very lucky that most of his injury was very superficial, caused a lot of pain for him, but overall prognosis wise, pretty good.
Awesome. That's a great case. One question came in on how to do with prior, or do you have to do prior authorizations with amniotic membranes?
Yeah, and so every insurance is going to be different. And I'm fortunate to work in an office that has some surgery counselors in it. And so we're able to call down over to our surgery counselor's office and they're able to obtain that prior authorization for us. Now, we use amniotic membranes so frequently, we know what insurances are going to require a prior authorization versus which insurances are not. And so when we call down to our surgery counselors, they say that insurance doesn't need one, you can go ahead and put it on today. Or that insurance does need one, let us make a quick phone call or internet inquiry, and we can do that. There are a couple of the amniotic membrane manufacturers actually have programs that their employees will do that for you. So if you do not have a surgery counselor, you can have that company. I know BioTissue does. So your Procura membranes, they will do your prior authorizations for you and they'll gather that information for you.
Yep, that's a great question. And then even if you don't need a prior authorization, or if you do and you get it, you also have to think about the patient's deductible. Sometimes these can be, $1,600-ish. And so nobody likes surprises. And so I like to just kind of go over with that. But I know sometimes hearing that number as optometrists, we're just naturally a very conservative profession that I know some of you are thinking, oh, I'm never going to bring that up to patients. But you would be surprised when I sit down and I talk to patients like, this is the cost. The reason why I'm recommending it is because I think it's going to give us the best outcome for possibly not having a scar, not having a recurrent corneal erosion, speed up our healing time. Don't prejudge the patient. Give the facts to the patient, make your recommendation, and then let them decide. Because a lot of times patients are like, all right, doc, if this is how you would do it for your eyes, then let's do it. Because, we all deal with deductibles, not anything new or different, but don't shy away from that. But also know that you probably need to have that conversation with your patients so that, so that they don't have a surprise that's there. So great question. Another one was with complete epithelial loss, how do you avoid missing it? Like when you're, how do you know? And then what are some tips and tricks for that?
Yeah, so what you're really looking at, and if you, Jessalyn, can you go back to the pictures of that case?
Yeah.
Because I think we'll be better able to explain it if we can go back to those couple of slides. But in this patient's case, if you look at the right eye, you can see the outline of where the epithelial loss is, but then you can kind of see how it's soaking into the stroma beyond where that epithelial loss is. That's what you're really going to be looking for, is how much the stroma is absorbing that fluorescein when you put it in. Because if there's an intact epithelium there, you're not going to see that spread of the fluorescein through the stroma. And so when you're watching it under the microscope, you can actually see that absorbing happen within that fluorescein pattern. And that's what you're going to be looking for.
A great question.
It was a really great question.
That is good. All right. Okay, well, let's go ahead and jump into our next case then. All right, so this is my patient, a 25-year-old African-American male called in and said, I have blurry vision. I have some black spots in my vision. Further uncovering of history. It started about 4 days ago when he woke up. He was definitely having some flashes of light. This is all just in his left eye. So, hearing this, listening to in a fairly acute flashes floaters, like this is one that we're probably going to want to see, like probably that same day, right? Like sooner than later, as far as triaging standpoint. So when he comes in, medical history, he does have epilepsy, but no other conditions, is on medication for the epilepsy, also uses an eye drop for redness. Interesting ocular history. He says, well, my right eye is blind. And so about 10 years prior to this visit, he was in the hall at school. One of his buddies popped him with a belt in the eye. He immediately lost vision. didn't have insurance, didn't have access to care. And so it was just like, well, kind of a bummer, but I still have my one eye, so it's still going to be okay. And so he's never sought care from that. Social history, nothing really jumping out. Looking at vision, he's right. That right eye is definitely kind of blind. So he has no light perception. Left eye 2200, no improvement pinhole. The right eye had a very fixed myotic pupil. The left eye was reactive, but it was very sluggish. It was round. He did have some confrontation restrictions inferiorly and temporally in that left eye. EONs were unremarkable. So looking at the slit lamp, looking at the right eye, you can definitely see that he's had some trauma. He had iridocorneal touch, a lot of iris atrophy. His lens had a really dense cataract. It was displaced a little bit because of this really mature cataract. There was no view into the back part of the eye. The left eye, cornea very edematous, had a lot of inferior KPs, had a pretty strong anterior chamber reaction, 4+ cells, 3+ flare. I remember looking at this, remember as a student, when you learned about flare, right? Like you did, like, what is flare, right? You didn't always see it a lot until you kind of maybe got out in clinical rotations. And I had seen it, through residency and whatnot. But in this case, I remember thinking like, bam, that is flare. It was like this almost like plastic sort of anterior kind of chamber that was happening there. He was sneaked. He had a lot of pigment on the anterior capsule, no real view into the vitreous, also hazy. IOP 7 and 10, dilation again, really dense cataract on the right eye, so no view. But the left eye, you can see, and this is, with my phone and the 20 diopter lens, because we couldn't really quite get it on a wide view photo. But you can see that there's, in the periphery, there's this kind of white infiltrative matter with a little bit of a adjacent kind of hyperpigmentation. And so we've got these kind of white retinal infiltrates that are happening out in the periphery. Did a B scan on the right eye. You can see a total retinal detachment, which kind of matches with the history and explains why his vision is also not where ideally it would be. So at this point, what is our diagnosis? So sympathetic ophthalmia, which we had kind of had as a differential for you on your first case. This is that condition where you've had trauma to one eye, then the other eye can have this kind of inflammatory response. So possibly that does kind of track. Or maybe we just have a full-blown kind of uveitis case because of something that is related systemically. So something like sarcoidosis, syphilis, TB, HIV/AIDS. When you think about the 4+ cells, 3+ flare, the vitreous was really hazy. We've got those peripheral retinal infiltrates, definitely thinking, all right, this is some sort of inflammation that's in the eye that's pretty significant and is likely because of something systemic going involved. So at this point, how do you manage this? Well, for other kind of uveitis cases, we're thinking about like adding in a topical steroid. Maybe we're going to cycloplegic, right? Like maybe if it's both eyes or if this is a recurrent situation, then we're going to order lab work. But in this case, the amount of inflammation that he had, like a topical steroid drop is not really going to touch it. This is a case where we've really got to figure out what this underlying root cause is, and we've got to get a prompt care. Depending on where you're at, location wise, you might have access to like a uveitis specialist pretty quickly. And so then you could loop them in really early on. Or if you don't have easy access to this, this is probably one where maybe you loop in a retina specialist or just send them straight to the ER. So in this case, I thought that something systemically is going on. We've got to get this guy pretty prompt care. I did get our uveitis specialist on the phone just to kind of tie him in because I knew that we'd ultimately need a referral. But I sent this guy to the ER and I called the ER ahead of time, gave him a heads up of just kind of what I was maybe thinking and some lab works to maybe consider once he got there. So he ended up having some labs done. The results popped back. It was inconclusive for FTA ABS. It was positive for RPR, but negative for HIV, negative for Lyme, negative for the different EBV, Western Nile, quantiferin gold was negative. Because it was positive for RPR, so we're thinking more syphilis. That's why he had the HIV kind of test done. And when you do have syphilis, then you also have to do a chest X-ray and do a cerebral spinal fluid assessment. And both of those thankfully came back unremarkable. So at this point, what is the official diagnosis? So it's a syphilic panuveitis. Panuveitis, remember, is that kind of term for uveitis when every segment of the eye is impacted. So we have the anterior segment, we have the intermediate, and then we have the posterior. When it checks all three of those boxes, that gives us this panuveitis kind of terminology. And then because of that positive RPR, we do know that this is in fact syphilis. So this patient then was hospitalized. He was given an oral steroid. He was also giving an IV of penicillin for 10 days. Quick reminder for anything syphilis related, there's different stages. There's primary, which sometimes can just be like a little painless canker. If it's secondary, then this is sometimes where you can get kind of a fever, malaise, maybe a skin rash. It becomes tertiary a lot of times when a patient's had it for decades, but also if it impacts anything neurological, which anything with the eye would fall under that, or anything cardio kind of vascular. So if it is impacting the eye, whether it's a kind of milder uveitis or more intense or something, that's like a lesion, we know that syphilis could be the great mimic. So it could look like a lot of different other eye conditions. But if it impacts the eye in any way, that's considered a neurological tertiary type of syphilis. And the way that we have to manage that is a little bit different. So to manage a neurosyphilis, a patient has to receive an IV of penicillin. There's an alternative if they have an allergy. They have to have their cerebral spinal fluid examined. They have to be tested for HIV. The co-infection between HIV and syphilis is like 60%. So it's one of those you definitely have to cross off the list if you do have a patient with syphilis. And these patients are also going to need a lumbar puncture kind of repeated every 6 months for 2 years. So a little bit of a, kind of long-term strategy care of to just be familiar with if your patient does in fact have this and you're kind of going through this journey. So this patient received oral steroids, IV of penicillin, ultimately was discharged, came back into the office, and vision was better. He was pinholing down to 20/50. Most of the uveitis, vitritis, all of that looked a lot better. But I put follow-up as ongoing is because to date, he has not came back in. It got his vision good enough that he felt like it was fine. And then, how these kind of emergency patients go, we'll probably see him maybe if something else pops up, but hopefully if we don't see him, that means that he's doing well and not having any eye things. So I would say, clinical pearls to remember is that if you have a uveitis, we know that that's inflammation. And if you suspect that it's something systemic, we have to navigate this in the best way. So sometimes that might mean you ordering lab work, or if you suspect, like in this case, the severity of it was just so intense. Like I felt like he needed to go to the ER and we needed to jumpstart this right away. But if it is something more mild, and less severity, you might, kind of do like a topical steroid. And then this is one of those cases too, is a great way to co-manage with different healthcare professionals so that you can, kind of showcase your knowledge and help give the patient the best care that's needed. And then remember that for neurosyphilis, that is anything related to the eyes, and it has a different kind of subset of treatment protocol according to the CDC.
I love that that patient is never came back. He's got a lot of trust in that one eye, man. A lot of trust in that
I
one.
feel like the theme for our patients today is like brand new patient, doesn't have a lot of history. Now is
Yes.
here for you to solve all their eye problems.
Yes. All right. So we're going to launch into this next case here, which I'm going to take some questions at the end on this. Would you guys have treated this an emergency or not? So that's kind of what I want you to be thinking of as we're going through this case. But another 15-year-old new patient presents into my office, waking up that morning that he woke up and has no vision out of his left eye. Reports that when he went to bed at night that eye was having a little bit of wavy vision, even throbbing a little bit. That throbbing has continued. He does have a history of migraines, and his mom, who had driven him to the appointment, said that he had a slight fender bender the week before with his driver's permit, maybe had backed into somebody, but no significant damage to the vehicles or significant damage to either him or his mom being in the car at the time. Was not on any medications, no known drug allergies as well. And so, the first thing that I'm looking at is the vision. And when you look at that left eye, no light perception, that's making me scratch my head a little bit. His pressure was normal. Pupils were normal. We did extraocular movement, visual field, confrontation field. Obviously couldn't see anything out of that left eye. But other than that, everything looked normal except for him not having vision in this eye. And so this really started putting up some red flags. What do we need to be doing for this patient? What do we even need to be considering for this patient who reports that he's always had normal vision and is now showing up with no vision out of one eye after just waking up? So what testing do we need for this patient? And so, in my opinion, we throw everything but the kitchen sink at this patient now because it's a child and we don't have any answers. So, looking at his optic nerve, OCT, and his macular OCT, I would put that in a textbook and teach off of it. I think it looks so good. I mean, they look fantastic there. So really, really pleased with both of those. If we move on to the next slide, we even did an OCTA on him. And Jessalyn, you can actually play that, I believe, or it should play as a little video. And you can see that he really had good blood flow. We weren't seeing any areas of ischemia through there that we needed to be concerned with. And so I was pretty happy with all of the testing that I was receiving. If we go to the next slide, this should be the visual fields. And I love that my technician attempted to perform a visual field on this no light perception eye. Sometimes you can trick a patient, but we were not able to trick him in any way. He did not click that button even one time, could truly see nothing out of this eye. And so this is when we said, okay, I think we need to get the pediatrician involved. So we called the pediatrician and we said, we have this mutual patient here. He woke up with no vision in the eye. Everything eye-wise is testing normal. What would you like us to do? And the pediatrician was like, you know what? I think we need to get some blood work and some imaging done. So why don't you go ahead, send him to the emergency room for that imaging. I'll put some orders for some blood work in. My aspect was like, I think I might want to get a neuro-ophthalmologist involved. We only have one in the state of Oklahoma, about an hour and 45 minutes from us at that same teaching hospital that I presented about earlier. So I said, let's call over there and see if we can get something scheduled for you as well. The optometry school is about 45 minutes, an hour from us as well. And they have a VEP ERG machine there too. And so I said, let's get that on the schedule and let's get you scheduled for that too. MRI comes back really within normal limits. These videos will play, but if we don't play them, that's fine too, because all you're going to see there is a 100% normal, healthy 15-year-old brain. There was nothing there that was ringing out that was abnormal. We were really happy with that report. Blood work all came back normal as well. And so this is really when we start questioning, okay, what's going on with this patient? Why doesn't he have any vision there? We sent for those VEP ERGs. Remember, VEP is going to be measuring from the back of the eye through the back of the brain. The ERG is going to be the front of the eye to the back of the eye, looking at the function of all that visual pathway. And all of those tests showed within normal limits. And so now we know it's not an eye and it's not a brain problem. What's going on with this patient? And so I believe the next slide should be the neuro-ophthalmology visit. And what we were finding with this neuro-ophthalmology visit was they were saying that he had some transient vision loss, which equaled non-organic pathology there, due to his migraine. So his migraines triggered this functional vision loss within this patient. And the neuro-ophthalmologist reported that it should be spontaneous recovery. They put him on some nortriptyline at that point, which typically is used as an antidepressant, but can also be used for migraines as well, and wanted him to continue to consult with a pediatric neurologist as well, continued migraine type treatments, so that this doesn't continue to happen again. And I think we can go to the next slide there. Perfect. And so we see him back a week after that visit, and he says that the vision has been improving in that left eye. When he covers his right eye, it almost appears doubled, but he's starting to be able to see at least something. He did mention that he had another headache, and after the headache resided, that the vision started to improve after that point, which I thought was really, really interesting there as well. And so I think we can go to the next slide again. I'm so sorry that my clicker is not working. We did some follow-up OCTs on him, and you can see that those OCTs still look very, very normal. We also did some follow-up visual fields, and you can see that at least he clicked the button a couple of times with this, but still that real generalized depression out of that left eye, although being able to see at least something out of that eye now. And so continued follow-ups, he came in about 3 weeks after that. The vision out of that eye was about 2100. A month after that, he comes in and he says he woke up that morning and his vision was completely back to 2020. So total time for this visual acuity resolution was just a little over 2 months. He is under care of the pediatric neurologist for those migraine control, hopefully endeavors now that will prevent this from happening again in the future. No additional incidences of this no light perception in that eye since this time. But this was the first patient that I had seen where a migraine with visual aura had transitioned into this functional vision loss that allowed the patient to not have any vision for over a 2 month period of time. I think that's something that we don't see super often or super regularly. And so it was a really interesting case that, do I think that when someone's calling into our office and saying that they don't have vision out of one eye and they woke up that morning with no vision, that's something that I've trained our front desk to bring in that patient emergently so that we can take a peek at it. But truly, was this case an emergency? Probably not. And so that's where things get a little bit iffy over the phone. In my opinion, it's always better to be safe than sorry. So bringing those patients in, doing your due diligence, making sure you're doing that documentation, and so that you can have for future issues or future problems that may arise, but also making sure that there isn't something more significant going on. I think that, oh yeah. And so functional vision loss, most common in teenagers. His a little bit because of that. Also, he was male versus female. It is more typical in females. According to studies, 20% of functional vision loss patients had a migraine or eye facial pain at the time of diagnosis, which is true in his case. But again, spontaneous is going to be it can be quite a period of time. In fact, I have another case that I'm dealing with that it took over 4 years for that vision to resolve. And so those timelines can look very, very different between patient to patient.
Wow, that's a crazy case. It's kind of a
Isn't it
good
so crazy?
reminder of how just migraines, of how just wild they can be, and yeah, it's good to just keep it as a differential for those patients where you do have to kind of walk through everything in the kitchen sink diagnostically to cross a lot of things off the list. So you guys did a really good job of tackling
Exactly.
that. Couple of questions. It looks like more on like normative data. Does Zeiss
Yes.
OCT have normative data for a 15-year-old and patients under 18? How do you kind of do that with
Yep.
the color coding?
Yep. So we don't. So what we've instructed our technicians to do is if we have a patient who's under 18 years old, we have them actually change the birth year when they're inputting that patient's information into the OCT to make them appear that they're 18 so that we can try to get some normative data there. Eventually, when they hit 18 years old, we'll go and edit their birth date into the actual age of the year of their birth.
Yep. The little hack there. Absolutely. We this might be our last case because we're almost at time. This is my patient. He was a 67-year-old Caucasian male that called in. I think he had called me from the golf course, if I remember correctly. And he was like, I can't see out of my right eye. It's kind of impacting my golf game. It started a couple days ago. Like, do you think I need to come in? Do I not need to come in? My wife keeps hassling me. And so, my staff came back and was like, do we need to see him? Do we not need to see him? And so I sent my staff, called him back, and was like, can we just ask a few more questions? What does it mean you just can't see out of the right eye? So uncovering more of the history. He also did have a headache on the right side of the head, did have some blurry vision just in that right eye, did have a little bit of fatigue, had some pain around the back of his neck for the last 2 weeks, had some scalp tenderness, did not have any jaw pain. So probably just based on those history questions and what I'm putting here, you probably know the direction that this case is probably heading in. Medical history, pretty much unknown. He hadn't had a physical in over 10 years. So no known medications, no allergies, had an eye exam 2 years prior, nothing remarkable other than cataracts. Social history, very unremarkable as well. Hand motion in the right eye at 4 feet, left eye 20/30, not really pinholing any better. Pupils did have an APD in that right eye, did have some restriction in the visual field. Eye pressure was 10. Looking at the anterior segment, everything looks great. You know, he did have kind of a moderate cataract, but nothing jumping out from an anterior segment. Looking at the posterior pole, you can see that that right eye is a little bit edematous. We've definitely got some change in tortuosity to the vessels that are there. And so at this point, what is our diagnosis? Well, we have a swollen nerve, we have an APD, you know, a fairly acute, we've got some neck pain, some fatigue. And so GCA with an AION is definitely kind of one thing that I'm considering at this point. So the American College of Rheumatology actually put out a kind of classification that as long as you have at least 3 of these, you can make an official diagnosis of GCA. And this is age of onset over 50 and onset of a new headache, tenderness or reduced pulsation to that temporal artery, elevated sed rate, or of course an abnormal artery biopsy. So this patient's in your chair, he's already kind of annoyed because you pulled him off the golf course to examine him. And how are we going to manage that, right? Like, what are these next steps? So at this point, I was like, all right, well, gotta send you to the ER, but called the ER and sent over a letter of like, this is what's going on. Can we start these lab once he gets there? This is, you know, kind of what I'm thinking the direction that we need to start heading in treatment wise. So labs that I'd recommended: CBC with DEF, SED rate, CRP, FBABS, ANA. SED rate came back. Of course, this was immediate. It took a couple hours of him being there, but definitely had an elevated SED rate. CRP was also elevated. The ER did go ahead and order neuroimaging. I didn't recommend that, but because he had the swollen nerve, and luckily this guy had a vascular surgeon that was like visiting Maine, and so he was able to actually get this artery biopsy done. In reality, that often never happens that quickly, and so sometimes, you know, ideally we want to do the biopsy before we start any sort of treatment because it can skew the results. And so I've had some patients to where we start on a steroid and you know, it's almost too late then to do the biopsy, just because of the access to get this can be a little bit limiting at times. Who does this? Usually a vascular surgeon, at least in my area. That those are the most common ones that will do the artery biopsy. His biopsy results did come back, and it did in fact confirm that this patient had GCA. Luckily, the neuroimaging was unremarkable, and so this patient was started on an IV steroid and then as well as an oral steroid. So saw the patient after he was released about a week later. The optic nerve still looked pretty edematous. He was feeling better systemically, like the neck pain was gone. He didn't have as much fatigue, but his vision was definitely decreasing. So he went from hand motion to light perception. So not great. He was still waiting his rheumatology consult. And at this point, I was just kind of watching. I wasn't changing anything that what he was doing. He was still on the oral steroids. And a lot of times these patients that do have GCA can be on oral steroids for 6 months, 8 months. And so sometimes you're also managing the ocular complications that can come with having a patient on oral steroids for that long. Saw the patient back a couple weeks later. The nerve looked no longer edematous. It almost looked like it had more perfusion, but it was just because we were caught in this little switcheroo from being swollen, moving into this optic atrophy, you know, phase that was coming down the pike. And unfortunately, at 2 weeks, we can see that the vision, you know, just a few weeks prior was at light perception, and then he was at NLP. And so no improvement to date, but luckily, his vision in his left eye is still 20/30. And so this is one of those hard cases that, you know, he called in fairly quickly when he had this change in his vision. He received care, you know, the stars aligned. He was able to get a biopsy and started on those steroids, you know, from when I saw him within 24 hours. But a real bummer that even despite having pretty fast care, he did lose vision. But also a good reminder that if he hadn't had that right care, who knows what would have happened to the vision in the left eye. So, a bummer on one hand, but also kind of a positive when you take a step back as well. So GCA, reminder, it's a very common vasculitis, especially in adults. More common in women statistically more than men, but in this case, this was a male. It is a granulomatous type of inflammatory vasculopathy that does affect the medium and large size arteries. And so the goal with any GCA is that ideally recognize it before the nerve starts to kind of be impacting it. Classic symptoms of GCA, headache, scalp tenderness, any sort of temporal artery or pulsation or tenderness there. Most of my patients who have GCA do have some sort of neck pain. That's usually like a pretty common thing that they report. Overall weakness, overall fatigue, maybe they have an unexplained fever. So of course, we're always thinking about the headache and the temporal area, but don't forget these other symptoms that can sometimes kind of pop in. With an AAION, this is that true ocular emergency that we have to keep on our radar, because if we don't promptly treat it, there's a 50% chance that the fellow eye can lose vision. And so this is one of those cases that if you suspect this, you got to move pretty quickly. This is an inflammatory condition, so the treatment is going to be, steroids, not a steroid drop, like, systemic steroids or an IV steroids to get that inflammation under control. And then remember that with the nerve, that is, in an acute phase, that nerve is going to appear pretty swollen. You might have some flame emerges. And then obviously later stage, when that optic atrophy sets in, you're going to get that pallor. Arteritic and non-arteritic, we're almost out of time, so I won't spend a lot of, kind of time reviewing that. But a good way to test for this is SED rate. So SED rate, we know, is how fast those red blood cells are settling to the bottom of the test tube, and it tests for inflammation. Be careful though, because I've had some cases of GCA where a SED rate has actually been normal. So lab work is helpful, but it's not a definite, positive or a definite ruling out either way. You have to take it with a grain of salt. And remember that sometimes a SED rate can be normal just based on the normative data of the patients that go to that lab. And so that's why it's important to really remember these equations and do your own calculation to make sure that it is truly kind of within a normal range and not within just the normal range for that lab, because sometimes you can get a little bit of a skewed result there. GCA can have a lot of other ocular manifestations. So you can get cranial nerve involvement, get diplopia, cotton wool spots, visual field, corneal infarction, any sort of nystagmus or kind of an INO, or even looking for anterior segment neovascularization, something that we would see with like an OIS. Treatment for that, other than a steroid, Actemra was FDA approved back in 2017, and it can be used. I think regionally, like some parts of the country use this and other parts don't, but it is a treatment that's not a steroid for GCA. And then GCA kind of has this loose connection with PMR, and so we're not sure if this is like a subset of a bigger umbrella, if they're two distinct conditions. So more research is really needed to kind of tease out how different GCA is actually from polymyalgia rheumatica. So clinical pearls, don't forget about a really thorough case history. Prompt treatment is really important. Ideally, you might have to start the treatment before you get the lab results back. If you suspect GCA, you got to get on these steroids pretty quickly. We'll go ahead and jump through and take any questions. And this is our email information. We are on socials if you need us. And thank you so much for spending these last couple of hours with us. Thank you to University for having us, and to Jen for moderating this fun lecture.
Thank you so much.
You made my job very easy. You guys moderated for each other. So if there's any last minute questions, I know we did. I know both of you are amazing at kind of moderating in the moment, which is super helpful sometimes because those questions can be so relevant in the moment when you're going through a case. So I do thank you for answering those. Are there any last minute questions? You've got a few minutes If anyone has anything that they didn't get asked, here's the QR code. So make sure you do scan that. I do see some wonderful comments, people saying, great lecture, thank you. I
Thank
agree,
you.
that was fantastic. And it's always a great refresher because you never know what is going to pop up. And I had a retinal detachment first thing Tuesday morning after Memorial Day. A friend of mine who, upon questioning, asked, when I asked her if she had noticed flashes, she said, I did, but I blamed it on perimenopause. So just never know what you're going to get, especially after a long holiday weekend. There was a question actually going back to case number one.
Yes.
Which specialist performed the surgery on that patient?
Yeah, so it was actually a combination of a few specialists. And so the Dean McGee Eye Institute in Oklahoma City had a retina specialist involved, a cataract specialist involved as well that tag teamed that case. And then an oculoplastic surgeon they were potentially going to involve as well as far as the iris. But those were the two surgeons who tag teamed that patient for the initial surgery that he had.
I have a question actually. Who would be on your Rolodex of people that you would want to be able to call in a moment? Phone a friend. What would be your top specialist if we were inspired by this lecture to, if you're in a rural location or you want to be more involved in these emergencies, but maybe feel a little underprepared? What would be your top specialist that we would want to have a good working relationship to send patients to?
Jessalyn, I'll let you answer that one just because I think you're in that situation more frequently than I am.
Yeah, it's a great question, and I feel like it's hard to pinpoint one. So I feel like I would have maybe some relationship with my urgent care or ER, just like even a fax number or a number to like send over your notes to, like even if it's just that, because that can be really helpful at kind of speeding things up, like lab wise. Also, I think a retina specialist, because sometimes when I think about the cases that start to fall a little bit outside of my scope is sometimes we'll remove more into the posterior pole where I need like a retina surgery, I need an injection in the back part of the eye, I need some retina docs in some areas might even be able to do like a temporal biopsy. Like we have one in our area that could do that. So I feel like that is one kind of relationship that would be really helpful. And then of course the patient's PCP, right? So for everybody, probably for insurance purposes, has to have a PCP, even if they don't go see them every year. But that can be a really great tool to kind of start forming that relationship to help get you the labs or the care or get you the referrals that you need. So that would be my recommendation.
Perfect. There was one last question, and we'll take one last one and then finish up so everyone can go take a break before our next lecture. Could you briefly discuss sympathetic ophthalmia? I know you mentioned it in that, I think it was the migraine case possibly, but could you discuss that a little bit more?
Yeah, so I think we mentioned it a little bit in my first case
Oh,
with the intraocular foreign body trauma, and then in one of Jessalyn's cases as well. And what you're looking at with sympathetic ophthalmia is this like inflammatory response that actually impacts the eye that did not have the injury or did not have the surgery. And so we want to make sure that we're taking care of any problems with the injured eye and decreasing that body's ability to form that inflammatory response to the injury so that it doesn't subsequently affect the healthy eye.
perfect. Thank you for that. I'm sure there will be more questions, but you both kindly shared your email addresses. So with that, I want to thank you, and I thank you for kicking off our second day with some amazing cases. We're going to take about a 5-minute break, so make sure that you are back at 10 a.m. Pacific, 1 p.m. Eastern for our last lecture in the WUU Emergency Summit. It's going to be Ocular Emergency and Trauma Grand Rounds with Dr. Major. So I will see everybody back in about now 4 minutes. Thank you, Dr. Quinn. Thank you, Dr. Bull. That was fantastic.
Thank you. Bye, everybody.
All right, welcome back, everybody. Hope you had a few minutes to take a break. And we are here in the home stretch for the last part of our Ocular Emergencies Summit. So thank you to everybody who joined us yesterday and today. It's such a wonderful event, and we're honored to have you spend your weekend with us. So Dr. Major is here to finish our weekend off with another amazing presentation. So I'm going to get started because I know she has a lot of great information to cover. How are you, Dr. Major?
I'm great. How are you?
I'm good. Thank you for being here.
Oh, my absolute pleasure. Thank you for having me.
Great. Well, I get the pleasure to introduce you once again. Dr. Major is a doctor of optometry and a fellow. Oh, I lost your
Sorry.
slide.
Sorry about that. I'm so sorry.
A fellow of the American Academy of Optometry and Optometric Retina Society. She received her doctorate of optometry from Salus University and completed an ocular disease residency at the Eye Institute of the Pennsylvania College of Optometry. Following completion of her residency, she served as chief of the Retinal Disease Clinic and as assistant professor at the University of the Incarnate Word Rosenberg School of Optometry for 8 years. In 2019, she joined Northeastern State University of Oklahoma College of Optometry, where she serves as director of residency programs and professor. Welcome, Dr. Major. I will let you take over.
Thank you so very much. It's a pleasure to be here with you guys. I guess either this morning or this afternoon, depending on where you are and what time zone you're in. So without any further ado, we'll go ahead and get started. So I did post like a more updated handout for you guys available on my Google Drive. If you want to follow the QR code here, I also posted a link in the chat box a little bit earlier so that you can follow along there if you want to. And then here are my disclosures. I'm a paid consultant and speaker for Zeiss, Regeneron, Iveric Bio, Astellas, Apellis, as well as Optomed. I'm also a paid advisory board member for Lens Therapeutics, Nodal Vision, Topcon, Tarsus, as well as Genentech, and all relevant relationships have been mitigated. And so, this is a grand rounds format type of course where we're going to talk about like trauma cases or cases that came into the ER. And what I really love is that it emphasizes the importance of continuing education and to continue learning and pushing yourself further to your limits. So when I transitioned from the Rosenberg School of Optometry over to the Oklahoma College of Optometry, and I took over the position as residency director, our residents are on call both in the evenings as well as on the weekends. And so as they were taking these call cases, I was kind of like the first line of backup. And I started encountering a lot of acute trauma and acute ER emergency cases I had never been exposed to before. And some of which made me very uncomfortable at first that I will share with you here today. But I think that if you push yourself, you continue learning. And so I put this quote here, which is from, I have two boys, they're 7 and 9. And so, they read a lot of books. One of their books called Elbow Grease. If you only stick with what you're good at, you'll never learn anything. And I think that's so important. It's really need to continue to challenge ourselves, see new cases, learn new things, so we can expand our scope and, provide our patients with the best care possible. I also want to tell you a little bit about my setting. So at the Oklahoma College of Optometry, we are affiliated with the Cherokee Nation and sort of like an IHS hospital type of facility. And so when our residents are on call, they may see patients in the ER, they may see patients in the urgent care. They may actually be asked to go see patients in the hospital ward or in the ICU. So a lot of these cases, you're going to see patients coming through the ER or they're actually hospitalized already, or they just came to our optometry clinic as sort of like an acute care case. But we're very fortunate to be in a setting where we can order labs, we can order neuroimaging and everything kind of on site immediately if we need to, which also very much helps in the learning. So this first case, entitled Another First for Oklahoma. In Oklahoma, we're very proud of our scope of practice. And I think this was probably one of the first surgical procedures that was performed by an optometrist in the nation. And so we're really proud of that. This is a 52-year-old male. He's coming into the ER, unfortunately having been assaulted and punched in the right eye about 3 hours prior. He's presenting with some double vision initially, but then he said the double vision went away when he completely lost his vision and the eye was so swollen it completely swole shut to the point where he can't even open it. Of note, he is taking some blood thinners as well as aspirin for heart disease, which may have contributed to some of the pathology in this case that we're going to see. His vision in the right eye is light perception, pinhole, no improvement. And when we do his extraocular motility testing, he has near complete ophthalmoplegia, so he can barely move the eye in any direction whatsoever. In terms of his pupils, when we pry the eye open and we do pupil testing, the right pupil is very poorly reactive, and he has at least a 3+ indirect APD in the right eye. And his limp examination, there's some subconjunctival hyperemia as well as an anterior chamber reaction, which isn't unexpected with a presentation of blunt trauma, some sort of like traumatic iritis. His intraocular pressure, however, is severely elevated. So it was 67 millimeters of mercury in this. We measured this with eye care over in our ER setting. In the right eye, 16 in the left. His dilated fundus examination was within normal limits. And so when patients come into our ER setting with a history of trauma, they immediately typically do a CT scan to rule out any sort of like orbital fractures, etc., before they even like call the optometry resident to come in and see the patient. So when the optometry resident got to the ER, this patient already had a CT scan in place that we were able to review. And as we go through this CT scan, so this is an axial cut CT scan. Remember, CT scans show bone and blood really well. So why they're so valuable in a trauma setting is that we can see fractures, we can see hemorrhaging, etc. So as we kind of go through these scans, and we are going from like mid-face kind of like up this way, so from bottom up to top as we go through these various cuts, you can start to see that there is a lot of periorbital edema and swelling, and you can start to see kind of this proptosis as well. He has really, really severe proptosis with that right eye being kind of prolapsed forward. And then as the radiologist is reading, they say that there is a collection of blood in the orbital cavity outside, they call extraconal, so like outside the cone of the recti muscles. So a retrobulbar hematoma. Remember, blood on CT scan shows up bright. So we have this collection of blood behind the globe, but within the orbit, pushing it forward and creating a high pressure environment. And here I just love imaging, so I got carried away here. So again, like this really severe proptosis as we can visualize here on this CT scan. What else they noted, and I think is best visualized on the coronal cut of the CT here I have on the next slide, is that he also had a fracture. So he had an inferior floor fracture as well, which in this case, you think, well, maybe this is a good thing because he has this collection of blood and like increased volume in this enclosed cavity that's causing increased orbital pressure. It's like, well, maybe this inferior floor fracture would help relieve some of that pressure and hopefully decrease the intraocular pressure. But in this case, I mean, clearly his intraocular pressure was still elevated severely, like close to 70. So I put in some poll everywhere questions throughout this, hopefully to kind of keep people a little bit engaged and hopefully participate through. I know we're kind of in the home stretch for the last lecture here of the series. But what are you going to do with this patient? What sort of treatment is indicated? Topical IOP lowering therapy, emergent referral to ophthalmology, lateral canthotomy, or you're just going to panic, which I think both the resident and I did initially at first, no lie. And this case was actually around the time of COVID. And so in Tahlequah, where the school is located, we actually don't have any ophthalmology in town. So like the closest ophthalmologist would be in Tulsa, which is about an hour, 15 minutes away. So I think you have to keep that in mind. We don't really have time in this case to leave the intraocular pressure at 70 and refer to ophthalmology. We want to lower the intraocular pressure. So, I think we did do topical lowering therapies as well as they had started an IV as soon as he came into the ER for some reason. So we pushed IV Diamox as well to try to immediately lower the IOP. But ultimately, it's really important that you do a surgical procedure to try to relieve some of that orbital pressure called a lateral canthotomy or a lateral cantholysis. So let's first discuss what is retrobulbar hematoma. You could think of this as like an orbital compartment syndrome. And the diagnosis is very much clinical. You do not need a CT scan to diagnose retrobulbar hematoma. All that does is kind of slow down the intervention, which we want to do as quickly as possible because usually the intraocular pressure is severely elevated. And we know that even like an hour of raised orbital pressure can unfortunately lead to irreversible vision loss. So the classic clinical presentation, decreased acuity and APD, proptosis, ophthalmoplegia, and IOP elevation, all of which our patient had. And so with regards to treatment, as we were kind of preparing to do the surgery, the lateral cantholysis, we tried to lower the pressure. So we did in-office topical IOP lowering with like COSOPT and brimonidine And I said we had pushed IV acetazolamide through his line as we're kind of prepping for the surgery. I had just started at the school teaching in Oklahoma, and I didn't necessarily feel comfortable doing this procedure myself. So I called my supervisor, who's now the dean at the Oklahoma College of Optometry, Dr. Nate Lighthizer, and I said, I'm here in Oklahoma, I'm gung-ho, I'm ready to do SLT, but I'm not really ready to just like cut through someone's eyelid. So I asked if he would come in and assist with this surgery, which he very kindly did. So I'm going to show you a video here of the surgery that we took. So first we signed an informed consent document. We cleaned the location with betadine. We numbed the patient with lidocaine subdermally, and it was lidocaine with epinephrine to try to reduce some bleeding. We also applied a hemostat, which is like a clamp, to try to reduce any bleeding as well, or at least limit it as much as possible. And here you can see he's using sterile blunt-tipped scissors to basically cut through the lateral canthal tendon. So he's cutting over to basically where you hit the orbital rim or the orbital bone. And what we're trying to do is cut through this tendon so that the eye can do what it naturally wants to do, which is like prolapse forward to relieve some of that intraorbital pressure. When done successfully, when you check the intraocular pressure, it should immediately be lower post this type of surgery. So we did this and rechecked the pressure, and it came down to 37. So at least we went from about like 70 down to 37, so we made some progress. In terms of when we let him go, in terms of the discharge, what we asked him to do was oral Bactrim because he had that inferior floor fracture. We wanted to prevent any like secondary orbital cellulitis from occurring. We dispensed oral acetazolamide, 500 milligrams for him to use every 4 hours, and then some topical IOP lowering meds, brimonidine and Cosopt every hour in the right eye. And then we also gave him some erythromycin ointment to apply to the area where we had made the lateral canthal-lysis, just to kind of keep it moist so eventually it's going to heal. We don't want to immediately close it up, right? Because it's serving a purpose right now, which is allowing the eye to basically proptose forward. So we're going to wait in terms of surgically repairing it, but we do want to keep the skin moist and prevent any infection. So he's doing erythromycin ointment 3 times a day. And of course, following him up very closely. So the resident, saw him the next day for an IOP check, etc. Here he is finally at his 1-month follow-up. So we repeated the CT imaging at this point, which is appropriate in order to not only follow up on that inferior floor fracture, but also to confirm that that retrobulbar hematoma resolved on its own. So retrobulbar hematoma doesn't require any surgical evacuation, right? It typically just self-resolves and reabsorbs. As what we can see on the 1-month CT scan, that hematoma had completely resolved, and that floor fracture was healing up very nicely without any sort of muscle entrapment or anything like that. And we also noted that the patient had spontaneous or like complete healing of that lateral canthal-lysis site without any surgical intervention needed. We did consult with oculoplastics to see if they wanted to do any like repair to make it look cosmetically better, but they said it healed up nicely on its own and they didn't feel that they need to do anything. So at the 1-month mark here, we can see he's healed up very nicely from that lateral canthal-lysis site without any sort of intervention. Unfortunately, his vision has continued to decline down to no light perception at the 3-month follow-up. And as we can see in his color fundus photography at baseline and the 1-day follow-up, so we're really fortunate to have a handheld fundus camera in our ER and urgent care over at the hospital that we can take fundus photos like in the ER. So 1 day it actually looks a little bit swollen, which is pretty typical of an initial insult to the optic nerve head, whether it's really severe IOP elevation, say like an acute angle closure crisis, or in this case, perhaps like a traumatic optic neuropathy, some sort of compression in the orbit of the optic nerve head. Pretty common that you get a little bit of swelling on day 1, which we can visualize here. And then at 3 months, we have just really severe neuroretinal rim pallor that's diffuse. And these are the OCTs as well as, or the nerve fiber layer OCTs as well as the GCC OCTs. And we can see over time, he at the 3-month mark has really severe and diffuse nerve fiber layer loss and GCC loss. So remember, he didn't come to the ER until probably at least like 3 hours after he had been punched. And then in the ER, they were triaging him, doing a CT scan. So like, who knows how long the pressure was 70? And so I think we just didn't get in quite soon enough to do the lateral canthalolysis to save the vision in this case. But I think, a good example of in retrobulbar hematoma, how time is of the essence. This is a true ophthalmic emergency. If it's a trauma situation, hopefully you could even perform the lateral canthalolysis on site if possible, say like a motor vehicle accident, etc. And we'll go to our next case. Don't see any questions. So this next case I've entitled, "You'll Shoot Your Eye Out." Oh, Ralphie, Santa and your mama are always right, right? So this is a 17-year-old male. He's coming into our ER accompanied by his mother Friday at 8 o'clock at night. He was playing with some friends with a BB gun and said that he was shot in the left eye, and he has reason to believe that there is a BB stuck inside the left eye somewhere. He's complaining of some decreased vision, some blurry vision, some redness, and some swelling. And the swelling's severe enough that he can't even open the eye. And then in terms of the visual acuity, it is slightly reduced in the left eye, but not too bad at 20/40, pinhole no improvement. The slow limb examination reveals some severe periorbital edema, conjunctival hyperemia, as well as some mild proptosis, as we're going to see on the imaging here in a minute. His intraocular pressures were a little bit elevated in the left eye at 45. And then the resident that did the dilated eye exam said she thought like maybe there was some Berlin's edema. And that term refers to commotio retinae, or like photoreceptor swelling in the macular region. But otherwise, the DFE didn't reveal any like retinal detachments, tears, vitreous hemorrhage, etc. I just want to ask you guys, like, what sort of imaging test should we do in this case? Would an MRI be preferred, or would a CT be preferred? And so a good take-home point from this lecture, and probably other lectures prior, CT imaging is really your workhorse in terms of imaging of acute care things. So like trauma settings, or in this case, we think there's a metallic, potentially intraorbital foreign body. So doing an MRI is definitely contraindicated, right? We need to do a CT scan. And usually you can do a CT scan without contrast in most instances of trauma or suspected metallic foreign body. Remember, contrast is helping you view like infection or inflammation. So if you have like an orbital cellulitis, a CT with contrast would be appropriate. But in this particular case, there's really no need for contrast. So we just did a CT scan without contrast. This is the Scout X-ray scan. And so if we think about like what a CT is, it's like a bunch of X-ray scans combined together to generate like this 3D model. So on the Scout X-ray scan, we can already start to see where this BP pellet is located here in the left orbit, kind of medially. And then this is the axial CT scans, and we're going to be going through several slices from the top down to the bottom. And so on this first image, I think you can appreciate that there is a lot of proptosis of the left eye, that there's some periorbital swelling here. And as we kind of go down, oh, I'm sorry, I missed one important point here, which is this little black circle in the orbital apex. So dark areas on CT could potentially indicate air. So there's a little pocket of air in the orbital apex, which is never a normal finding, right? We could refer to this as like orbital emphysema. And so I think when that BB pellet came through, it carried like some air with it because there wasn't any sort of medial wall fracture or anything, which could also cause orbital emphysema. And as we go down through some of these scans, I want you to pay attention to this muscle right here, which is the medial rectus, because that BB pellet, which is highly bright here or hyperdense on the CT scan, is tucked kind of like right under the medial rectus. But the radiologist is reading this as an intraconal metallic foreign body, meaning it's within the cone of the recti muscles. And note how close it is to the optic nerve head. It also seems to be buried like way down in there, like almost up against the medial wall of the orbit. Got carried away with imaging again. I just can't help myself. Go. So our assessment was retained left intraconal metallic BB pellet, basically, with ocular hypertension. So like, what's the mechanism of the IOP elevation here, right? So we said the IOP was 45 in this patient's left eye. And I think the reason being is there's just a lot of swelling within the orbit that's kind of pushing on the globe a little bit. So certainly we needed to address that raised intraocular pressure. And so in office, we actually did, or in the ER, several rounds of topical IOP lowering medications, Cosopt and bromonidine, and gave him some to take home with him to continually lower the IOP until we could check him the next day. Because he has this intraorbital foreign body, there's a potential for orbital cellulitis to form in the future. So we kind of prophylactically prescribed a broad spectrum antibiotic, I think probably Bactrim or something like that we gave him, as well as some cold compresses and potentially acetaminophen to help decrease some of the swelling and assist with the pain that he had in this particular case. And then I had the resident call the oculoplastic doctor on call, because remember, this was like Friday night. And they said, we'll just leave it in there over the weekend. We'll see him on Monday. And I remember thinking at the time that was like really inhumane that they were going to just like leave this BB pellet in the orbit over the weekend. But as it turns out, they end up leaving it in there for life. And one other thing we didn't do in this case, but we probably should have in hindsight. Hindsight's always 20/20, right? I'm willing to admit my mistakes, is tetanus prophylaxis. So here at the 1-day, 2-day follow-up, that this is the resident now seeing the patient in ER over the weekend. His vision improved from 20/40 actually down to 20/25 on the 1-day follow-up. His intraocular pressure was under 30, but still a little bit elevated. So we adjusted his topical meds just a little bit to try to lower the pressure a little bit more. At the 2-day follow-up on Sunday, his IOP was 21. He's doing well. And he eventually sees the oculoplastics ophthalmologist 2 weeks later. His vision is 20/25 plus 1, really impressive for how close that BB pellet is to the optic nerve. His IOP off of all meds at that point was 11. And the oculoplastics doctor recommends against surgery to remove that BB pellet, that they thought it would be riskier to remove it because it's so deeply embedded and so close to the optic nerve head, as opposed to just leaving it in place. So this patient basically can never have an MRI for the rest of his life because this BB pellet is in place. And I think just the general take home of this case is that small, inert, and deeply lodged metallic foreign bodies are generally well tolerated. So I had to look up like what is a BB pellet made out of? I didn't really have that knowledge naturally. So BB pellets are made of steel, commonly coated with like zinc or potentially copper. So, the coating of zinc is something that can remain in the orbit long term. If you have an intraocular, intraorbital foreign body, that's a material that could cause an inflammatory reaction, such as like lead, copper, iron, or like vegetative matter, that may be something that actually then needs to come out. But in our case, this is like an inert material, so they just left it in place. And I see there's a few questions about this case. How long between drops and the rounds of drops? So let me go back just a slide here. Yeah, so when he first presented to the ER on Friday, we typically do rounds of drops like every 10 or 15 minutes, give or take. And I think we just continually check the pressure until he left. Ideally, I would like the pressure under 30 before a patient leaves the office, but sometimes you just can't get there. In this particular case, I think getting him from like 45 down to 30 wasn't a problem. If it was, I would have considered something like oral acetazolamide in this case if I can't get the pressure low enough. And then explain when to get a CT scan with contrast versus without. Yeah, so in most cases of like trauma or suspected metallic foreign body, you do not need contrast. However, if you suspect there to be some sort of inflammation, infection, or infiltration, contrast is indicated. So let's think about orbital cellulitis, or you think there's maybe an orbital tumor and you want to light up the tumor, contrast is a good way to do that. Or some sort of inflammation, that would be another good reason to use contrast. But in this particular case, it wasn't indicated. Or if you're just looking for like a fracture following trauma, again, contrast isn't necessary. Great. And we will move on to our next case entitled, Crush It. Crush It Good. So this was a 22-year-old male. He came to our ER complaining of a central black dot and missing vision in his right eye since he had a motor vehicle accident the day prior. So when he had the motor vehicle accident, it was really severe. He was actually knocked unconscious. He wasn't wearing a seatbelt. He was found to be at fault. And I think what happened is that his chest hit the steering wheel at the time. His airbags did deploy. He's unsure if he had any sort of head trauma, but he said that they did a CT scan of the head and the orbits at this other ER that he went to yesterday, and that was within normal limits. But he's saying they didn't address his vision loss complaint. So he's now going to another ER saying, I don't know why my vision is missing in that eye. Is there anything I can do to try to recover it? His medical history, he just has some high blood pressure. We had seen him, he was like a patient in our clinic over at the Cherokee Nation Hospital, and he was priorly correctable to 2020. When we're seeing him in the ER in the right eye, his vision is hand motion, pinhole, no improvement. In terms of his entrance testing, he does have a significant APD in the right eye and some restricted confrontation visual field. In terms of the slit lamp examination of the right eye, he has a little bit of a subconjunctival hemorrhage, but otherwise within normal limits. There wasn't any anterior chamber reaction, and his IOPs were good at 15 in both eyes. And so this is like I think this was like the 1-day follow-up or something actually in our optometry clinic where we're able to acquire wide field and ultra wide field imaging. This is the unaffected left eye, which everything, looks good here, just some like white without pressure looking stuff. And then here is the right eye ultra wide field imaging. The resident that called me on this case actually said, I think the patient has a full thickness macular hole, which I think is a very reasonable differential in this particular case. But I think there's some other differentials we should potentially consider. And I'm going to mag up here so we can look at the findings a little bit more magnified or detailed in view. We can see there's areas of retinal whitening. They seem pretty like superficial in the sense that like it almost looks like some of the whitening is obscuring your view of like the big vessels, which we know are located in the nerve fiber layer. So this swelling seems pretty superficial. There's some intraretinal hemorrhaging in various locations here of the posterior pole as well as sort of like a splinter hemorrhage on the margin of the optic nerve head. And then this retinal whitening is giving the foveal appearance sort of a dark hue, which I think is why the resident thought that maybe this was a full thickness macular hole. I would love to see what you guys think in terms of what the diagnosis is in this case. And this was the first time I was presented with a case of this, and so I had to quickly like look it up and think about what treatment options would potentially be available, etc. So we have our first differential diagnosis given by the resident, which was a macular hole. If you guys want to go ahead and put in some other potential diagnoses that you're thinking about. Anybody still awake out there? Yeah, I love it. Commotio retinae. Certainly any retinal whitening after a history of blunt or head trauma, I think definitely commotio retinae is something that you should consider. We know that commotio retinae is like inflammation or thickening of the photoreceptor, so outer retina. So because our patients like swelling looks more superficial and spares like the foveal region, we know it's more anterior in the retina versus commotio retinae, which would be more like posterior, deeper at the photoreceptor level. But definitely a differential that was on my mind. And then Percher's retinopathy, which is the actual diagnosis in this case, was like the leading differential, and I'll go through that discussion slide here in a minute. Another thing I considered, right, is sort of like a foveal cherry red spot, was a central retinal artery occlusion. So there are cases following long bone trauma where patients develop central retinal artery occlusions due to like bone marrow being like fat, right? And so when you have a long bone fracture, it disperses fat emboli into the bloodstream that can travel to the eye and potentially cause a central retinal artery occlusion. So it's something we considered here, but remember he had already had like a CT scan and he didn't have any fractures or any breaks or anything at the time of the motor vehicle accident. Everything was normal there. So we were able to rule out potentially a central retinal artery occlusion, which left us with potentially Percher's retinopathy. This is the OCT, which also helps us rule out commotio retinae. Right, so we know that commotio retinae occurs at the level of the photoreceptors. Here our photoreceptors are okay, so we know that that's not the particular case. We know that the area of opacity or thickening in this case is superficial, and we have this interretinal hyperreflective thickening kind of the nerve fiber layer that is consistent with like interretinal infarction, which is like the etiology of Percher's retinopathy. This patient also had some, like, I guess you could call it like macular edema, or this little pocket of subretinal fluid. And because there was this little pocket of subretinal fluid, it was kind of like trying to research this on the fly. It looked like there were some case reports of retinal specialists treating like macular edema and Purchase retinopathy with anti-VEGF therapy. I asked the resident to call the retina specialist on call and see if they thought maybe he would warrant anti-VEGF therapy. He did call the retina specialist and they felt that no treatment was necessary in this case. So unfortunately, it was just observation. We didn't have any standard of care treatment to offer him in this case. So Purchase retinopathy occurs following like severe head trauma, chest compression, or crush injuries. We said long bone fractures can cause something that looks like it too, almost like a central retinal artery occlusion. And typically this presents with acute vision loss within 2 days of the injury. And classic fundus features include these Purchase flecken, which are these white polyagonal areas with perivascular sparing. So if we look at the retina right adjacent to the vessel, it's usually spared or not white or opaque. You can also get caught in mold spots like intraretinal hemorrhaging like our patient had as well. Unfortunately, treatment is usually supportive. Steroids have been tried, anti-VEGF has been tried without, mostly case studies. There's no like large randomized clinical trials to really support any diagnosis being superior versus just observation alone. And typically the prognosis is poor and most patients do not recover vision. Remember, in our case, we did talk to retina and they felt that no anti-VEGF therapy was warranted. They recommended observation alone. So here's our patient at baseline compared to our 3-week follow-up. You can see a lot of that retinal whiting that was present initially has actually improved quite a bit, but then he has these strange areas of like additional smoldering, like intraretinal hemorrhaging that keeps sort of coming and going. On his OCT scan, we had like spontaneous resolution of that subretinal fluid at the 3-week follow-up. And some of that hyperreflective interretinal thickening is starting to decrease. And we can start to see looks like there's probably some atrophy of like the photoreceptors in the retina centrally too. There's certainly some disorganization there that's going to contribute to long-term visual acuity loss. And unfortunately, he was still hand motion at this 3-week follow-up. He never recovered any vision back. So monocular precautions is an important thing to discuss with this particular patient. And let me see if there are, I think there's a question related to the BB pellet case. Would airport metal detectors pick that up too? I got asked that in a live lecture also at one point in time. I don't know. I don't think it's big enough that it would. I highly doubt it, but I can't say that with certainty, but a very good question. And moving on to our next case. So, I have several cases in a row here. They're all kind of related to blunt trauma. And so this first blunt trauma case is a 20-year-old male. And this is a walk-in patient complaining of a foreign body sensation following some trauma in the left eye. So he's like a yard worker and he was working with a coworker that was edging like a bush, and the edger like threw up a rock that kind of like hit across his left eye. He's saying he has some decreased vision as well as some pain, 9 out of 10 in the left eye. He's not complaining of any flashes or floaters. In terms of his past ocular medical history, it's unremarkable. His vision in the left eye here, which had the trauma, is slightly reduced to 20/40, pinhole no improvement. And we can see in terms of the slit lamp examination, he has this nasal bulbar conge and nasal peripheral corneal abrasion. So this is following fluorescein installation that extends onto the cornea, but not centrally, that is. And then he has, just some general injection of the bulbar conge, etc. In terms of intraocular pressure, it was within normal limits at 17. It's so very important, I think, following blunt trauma and high velocity trauma that you dilate patients and screen. In blunt trauma situations, right, we're looking for potentially retinal breaks, like a retinal dialysis where you have a separation of the retina at the aura is a common retinal break that can occur following severe ocular blunt trauma. But retinal tears, like flap tears, can also occur, and tears following trauma should be treated if we look at some of the standard of care guidelines, because they commonly lead to rhegmatogenous retinal detachments. So it's really important for us to dilate this patient, look for tears, look for breaks, look for detachment. We also know that blunt trauma can cause like choroidal ruptures, commotio retinae. So many reasons why we need to look at the retina in this particular case. When we look at the retina, this is the like wide field and ultra wide field color fundus photography. We have this area of peripheral retinal whitening, which is commotio retinae in this particular case. You see the blood vessels are going over top of it. This area of whitening is like deeper down at the photoreceptor level. Also, we have some minor intraretinal hemorrhaging, not uncommon, though that would occur in cases of blunt trauma as well. So due to the corneal and bulbar conj abrasion, we prescribe some prophylactic topical antibiotic therapy, moxifloxacin, 4 times a day for 5 days, and artificial tears to again help heal that corneal abrasion every 2 hours. Educate him on signs and symptoms of retinal tear and detachment. We didn't see that present now, but important for him to watch out if anything changes to come back and see us sooner, and schedule a follow-up for 1 week. So here he is at the 1-week follow-up. Miraculously, that area of commotio retinae resolved spontaneously within 1 week on its own. Even that area of intraretinal hemorrhaging resolved. And so commotio retinae, there's no treatment that's required, just observation is recommended. If it's outside the macular region, the visual prognosis is excellent, and it typically just resolves on its own within the course of like 1 to 6 weeks, depending on how severe or how large the area of commotio retinae is. His corneal abrasion at this 1-week follow-up was also healed. His vision was 20/20, IOPs were good. Now that the corneal abrasion is healed, I think there's additional tests that we should do, and certainly I would also do in cases, well, any blunt trauma, but especially if the patient initially presented with a hyphema. So patients with hyphema, initially, we don't want to do gonioscopy because it can cause a rebleed, right? That we could potentially worsen the hyphema by doing the gonioscopy procedure. So typically in a situation of hyphema, once the hyphema has resolved, like, I don't know, depending on how bad it is, like 6 weeks or so, at that follow-up, I'll then do gonioscopy to screen for angle recession. So we know angle recession is something that can occur following blunt trauma, where it's literally like a rip in the ciliary body, and it causes trauma to the angle such that it affects the conventional IOP or like aqueous outflow system. And so patients with angle recession have a risk for glaucoma for life. Like some patients develop it sooner than later, but it's something you always want to watch out for. The greater the circumference or degree of angle recession, the greater the risk for future angle recession glaucoma to develop. Fortunately for this patient, he only had 1 quadrant of angle recession, which was the same quadrant where all this commotio retinae was present, so over nasally in the angle. But his IOP was 11, so at this point he's good, but we did counsel him on the importance of coming back for at least yearly examinations to do an IOP check to ensure that he doesn't develop angle recession glaucoma in the future. But with just 1 quadrant of angle recession, it's quite unlikely that he's going to develop it anyway. And so just a review of commotio retinae, we know this is like a concussion, you could think of it as, or like swelling inflammation of the photoreceptors. So this is outer retina photoreceptors due to the forces of blunt trauma. Typically when the macula is involved, we refer to it as Berlin's edema. It's important to differentiate an area of commotio retinae, like our case, from a retinal detachment, from like a retinal break or retinal dialysis. In terms of management, you can just observe palliative care. Typically, it's going to resolve on its own. Our patient resolved in 1 week, but up to 6 weeks. And any questions on that case? Let me see. What if the pupil is involved, dilated, or fixed? Yeah, that's a great point. So another consequence of blunt trauma could be like a sphincter tear potentially. And so a sphincter tear would cause pupillary dilation, so anisocoria greater in bright. I love looking for sphincter tears in the slit lamp. So when in the slit lamp, you can adjust your light beam width. So make it like almost nothing to like boom really wide, almost nothing, boom really wide, to see how the pupil constricts. And in areas where there is a sphincter tear or say like sphincter palsy in a tonic pupil or something, where it's just one area of the sphincter that's broken, you'll see the rest of the pupil like constrict really briskly, but in that area of the tear, it won't constrict. And so I think that's a great way to help detect sphincter tears. You can often just see the tear too on like slit lamp examination. And often those cause permanent pupillary dilation and anisocoria. So you might want to consider some treatment for that, potentially like a mild miotic, potentially, or if it's like really severe with like really severe pupil dilation, like a cosmetic contact lens with like a painted on iris or something like that. Usually those cases aren't quite so severe. Great. And so we're kind of going on this series of like blunt trauma things. So this is more of a chronic presentation following blunt trauma 6 years ago. So this is a 32-year-old male. He's had some vision loss left eye more so than the right, but does involve both eyes since he had really severe trauma and assault 6 years ago. So he had not only, I think, ocular trauma, but also a lot of head trauma. The head trauma was so severe that he had like cranial fractures. So he's had brain surgery. He has metal plates put in his skull because of these fractures. He also has epilepsy as a result of this severe head trauma. He's had facial reconstruction done. So this is really, really severe blunt assault, not only of the eyes, but also the head as well. Just to kind of give you an understanding of how severe the trauma actually was. So in his vision in the right eye is actually not too bad, 20/50 -2. The left eye is 2400. We can see on just the color fundus photography here that he has some macular scarring here in both eyes, worse in the left, and also some scarring or pigmentary changes in the peripapillary region, as well as some optic nerve pallor, so potentially some traumatic optic neuropathy component as well, certainly worse in the left eye compared to the right. Here's the OCT scan of the left eye. I mean, really severe, like fibrotic material, RPE scarring. Now you can see like there's almost like this fibrous sheet that is like covering the retina anteriorly. A lot of pigmentary scarring. Unfortunately, nothing that can be done for the side 2400 vision that's unrecoverable. But here when we look at the right eye OCT, we see some interesting findings that I wanted to point out as potential consequences of blunt trauma. One of which is macular hole. So he has a full thickness macular hole present. Although it's hard to see clinically because there's pigmentary scarring underneath. Right? Typically a macular hole is going to be like a round red circle with like pretty well demarcated borders. It doesn't look red in this case, I think, because we're seeing down through to like some RPE hyperplasia. So it doesn't have like your classic appearance of a macular hole, but on OCT, we definitely have a full thickness hole present. We also have in the peripapillary region, this like crescent or, I don't know, semicircular type of scarring in the peripapillary region there, a choroidal rupture. And this is a really classic presentation of choroidal rupture. And the OCT helps us understand what a choroidal rupture is, which is a break of Bruch's membrane. And remember, Bruch's membrane is attached, or it attaches, I guess, the RPE down to the choriocapillaris, right? And Bruch's membrane is kind of like the glue that sandwiches things together there. And so when we have a break in Bruch's membrane, we often have a concurrent break in the RPE, right? So if we look at the RPE here, we have like missing RPE in that area of the Bruch's membrane break. And remember that the RPE represent like our outer blood retinal barrier, right? So we have tight junctions between adjacent RPE cells, and when that's ripped open, it's going to allow blood or fluid in the acute phase of a choroidal rupture to enter like the subretinal space. But long term, it can allow new blood vessels to go through that break in Bruch's and then proliferate in the subretinal space. So we can end up with subretinal or choroidal neovascularization as sort of a long-term consequence of choroidal rupture. So the fact that we have this like white subretinal material here with a choroidal rupture, like right in the center of the foveal region, highly suspecting that this patient has a choroidal neovascular net, which is this right here, in addition to a macular hole like on top of the choroidal neovascularization. So of course we did OCT angiography to try to confirm that there was a choroidal neovascular membrane there. And you want to focus on the preset that's called like outer retina or outer retinal choriocapillaris. This here is the choriocapillaris slab. So we're kind of sandwiching that area of subretinal fibrotic material. The red overlay is telling us that it's perfused tissue. And then we can actually see this like well-formed neovascular net on our choriocapillaris in FOS OCT angiogram. And so I think an important take home here, choroidal rupture poses a risk for development of choroidal neovascularization in the future. Typically, choroidal neovascularization, following anything really, would be potentially treated with anti-VEGF therapy. So the question is this neovascularization active or not? We're not seeing any blood on clinical examination. We're not seeing any fluid on OCT. So this choroidal neovascular net seems like it's pretty inactive, probably doesn't require any treatment of itself. I then questioned, do we want to consider treating the full thickness macular hole, right? It's been there probably for 6 years. It's also like if we do, so to repair a full thickness macular hole, right, we'd have to do a pars plana vitrectomy. And typically you perform an ILM peel to try to induce some scarring, like a gas bubble tamponade with face down positioning would be your surgery for macular hole repair. If we go in there and start to fiddle, like peeling the ILM and that, could we potentially wake up this choroidal neovascular net, right? Like kind of like tickle the tiger sort of situation. And so I told him we could consult with retina, but I didn't think that they would treat the macular hole because of this like neovascular net underneath. And he didn't really have an interest in doing any retinal consult. So in this particular case, we just did observation alone. Certainly it's important to, especially because this is basically his only seeing eye, this was 2050, his other eye was 2400, to monitor this eye frequently with serial OCT imaging. Probably every like 3 to 6 months, I think would be appropriate in this case. We also referred him to low vision, and he was very thankful for that as well. Great. And then I also wanted to show you a case of an early, like acute choroidal rupture. So we were just looking at one that was like 6 years old that had, neovascularization develop. If we look at a choroidal rupture in the, like, boom, the day that it happens, right? Remember we said you have a break in Brooks membrane, which is connected to the choriocapillaris. So you have this shearing of the choriocapillaris when you break Brooks membrane that allows blood from the choriocapillaris to enter the subretinal space. So it's very common to have a subretinal hemorrhage in the instance of acute choroidal rupture, which we can visualize here on this patient. This was a 38-year-old male with, he suffered some blunt trauma 5 days ago. So this was like 5 days after the trauma. His vision in the side was 2400. I think as a result of, you can see sort of there's some commotio retinae involving the center of the fovea there. Here's the OCT as well as the fundus autofluorescence imaging at baseline and then the 1-week follow-up. So on the OCT initially, we can see that there is some like thickening and hyperreflectivity of the photoreceptors, which is consistent with commotio retinae in the foveal region. He also has this little pocket of subretinal fluid that's kind of extending past the area of subretinal hemorrhage. And again, just think of the mechanism here. We have a break in Brooks membrane, a break in the RPE, that fluid and blood from the choriocapillaris can just freely enter the subretinal space. So I think this fluid is just related to that acute choroidal rupture. It would take longer for choroidal neovascularization to develop following rupture than just 5 days, right? So this isn't like a consequence of active neovascularization. It's just the fact that Brooks membrane and the RPE was ripped open very acutely. And then on the fundus autofluorescence, I think what's interesting on follow-up is it helps show you outer retinal RPE dysfunction. So in patients that have, we said, commotio retinae affecting the photoreceptors, you can have this like stippling sort of granular appearance. And we can see it has like atrophy of the outer retina. So this was like some really severe commotio retinae that unfortunately left him with some permanent vision loss of like 20/80 here at the 1-week follow-up. We can see there's some permanent photoreceptor damage on FAF and some permanent outer retinal photoreceptor atrophy on our OCT here on follow-up. So this patient, really important that we monitor him long-term for resolution of this subretinal hemorrhage, as well as for life, monitor him for choroidal neovascularization, repeating macular OCT, at probably pretty frequent follow-up intervals in the future. And any questions on that case? I'm not seeing anything. So we are moving right along. Our next case is another case related to blunt trauma, and I've entitled it, "But the nerve looks normal." So the resident called me, it's like, the guy's vision's really bad, but I have no idea why, because everything looks okay, other than the APD and the vision. So this was a 57-year-old male. He came into our ER saying he can't see anything out of the left eye since he fell in the shower the night before. He's not complaining of any sort of eye pain or anything. And you can see on presentation that he has this laceration of his upper brow as well as his forehead related to this shower fall that he had. And our ER is pretty good about doing a CT scan when patients come in with trauma, which was within normal limits in this case. They also did some urinalysis on him to screen for drug use, and they found that his ethanol levels or ethyl alcohol levels were elevated in the ER that morning. So it's either he was drinking that morning or he was drinking so much the night before that the levels were still elevated on urinalysis like the next day. So it's something to keep in mind, that I think the shower fall was probably related to him being drunk in some way. His distance visual acuity, the left eye, no light perception. Like what he's telling us, he can't see anything out of the left eye, unfortunately. But at his previous eye exam with us, because he was a long-term patient of ours, his vision was correctable to 20/20 before. So this is definitely a severe decline in vision for him. In terms of pupil testing, he has a reduced direct light response in the left eye, as well as a 4+ APD in the left eye. His EOMs and the eye itself actually looked really quiet within normal limits. The resident dilated the patient, which was very appropriate. These are the handheld fundus camera photos from the ER that same day. And so this is why the resident was looking, she's like, the nerve looks good, the macula looks good, there's no detachment, there's no vitreous hemorrhage. Like, she's confused as to why the patient's vision is no light perception in the left eye. Let's go back for just a second. One thing to consider, especially if it's work-related trauma or assault or something, would be malingering, right? So a patient that maybe could financially benefit from proving that they had vision loss from a traumatic accident or whatever. But in this particular case, I mean, this was him just falling in the shower, so he doesn't really have any motivation to potentially malinger in this case. Also, you can't fake an APD, right? So we know there's legitly some issue, and usually an APD is a really specific sensitive marker for optic nerve damage. You can get it in retinal damage, but you have to have really extensive retinal damage to cause an APD. It's usually pointing to some sort of optic nerve issue that's asymmetric, right? And so we're thinking there's an optic nerve problem. We just don't understand why the optic nerve looks normal. And I think it's indicative of the optic nerve trauma or damage being back behind the papilla, right? That we can't see it, something retrobulbar that's occurring that we just can't visualize. Also, I think what's really important is that they did the CT scan in this case. So if you're maybe in a private practice or something and this patient comes to see you, certainly you'd want to send them to the ER to get a CT scan done, because patients that have traumatic optic neuropathy, which this case is, could potentially have a fracture of the bony canal, where there's a bone fragment that's piercing the optic nerve or something that could potentially require surgical treatment. In this case, there's nothing that we can potentially repair. And CT scan in acute traumatic optic neuropathy is often negative. We can actually see the damage of the optic nerve itself. This is really classic traumatic optic neuropathy case. We had him come in the next day to just get some CT scans to make sure we weren't missing something like, commotio retinae or a macular hole or something that could be contributing to the vision loss of the left eye in this case. And so here we have both the NFL optic nerve head OCT as well as the GCC scan. This is the right eye and this is the left eye here. So he has some temporal nerve fiber layer thinning in both eyes and some rather diffuse GCC thinning, although it seems to be almost secocentral related, right? So if you think about the nerve fiber layer, we have the papulomacular bundle, which goes from the temporal aspect of the optic nerve over to the foveolar macular region. So it looks like we have loss of the papulomacular bundle in both eyes. And certainly, we wouldn't expect traumatic optic neuropathy to cause damage like this on OCT so quick, like 1 day later, right? We don't typically get atrophy from traumatic optic neuropathy until, I don't know, like 1 month to 6 weeks. We'll start to see OCT changes. So this is something that was inherently present before he had the trauma. And when we have loss of the papulomacular bundle, in addition to potentially like temporal neural retinal rim thinning, cecocentral visual field loss, had we done a field in this case, I would be suspecting something also like nutritional toxic optic neuropathy. And if we go back, remember, it's likely that he was drinking at the time he fell in the shower. And so he's probably, unfortunately, like an alcoholic that's getting poor nutrition. And our OCT is kind of confirming that he has this like toxic nutritional optic neuropathy in addition to traumatic optic neuropathy now present. Here on his macular OCT scan in both eyes, things look good here on the 1 day follow-up. So we're able to say this is probably traumatic optic neuropathy. There's no macular retinal issue present. We asked him come back in 6 weeks because for traumatic optic neuropathy, which is indirect, where there's no fracture or like blood collection in the subarachnoid space of the nerve or anything like that, there's nothing we can treat, unfortunately. So we did observation alone, see him back in 6 weeks to repeat our OCT scans, and we would expect to see atrophy at this point. So usually following traumatic optic neuropathy, as early as like 4 weeks or so, you can start to see some thinning. So this is a comparison scan between baseline and then the 6-week follow-up. We can see he has reduced nerve fiber layer, not only temporally now, but also kind of superiorly, as well as some like severe diffuse GCC loss also. And his vision never recovered. Unfortunately, he remains no light perception. So traumatic optic neuropathy we know can result from head orbital or globe trauma or orbit trauma, excuse me. It may occur with even minor head injury when it's right in the right spot, which is where those forces can be transmitted back to the orbital apex or the bony optic canal where the optic nerve is passing through. Often that sweet spot of trauma that results in traumatic optic neuropathy is like the frontal bone or the brow. And so commonly, bike falls, apparently, when you fall, hitting the brow is a common thing that occurs and can cause traumatic optic neuropathy. Remember our patient, if we look at the location of his trauma, it's right at the upper brow, which is a common location to cause traumatic optic neuropathy. And we can have direct or indirect traumatic optic neuropathy. So direct would mean there's something actually piercing the optic nerve, whether it's like a bone fragment from a fracture, or there's some sort of like optic nerve sheath hemorrhage, or an optic nerve avulsion, where the optic nerve is actually like pulled out of the globe. That's something you can't treat, but potentially like a fracture or an optic nerve sheath hemorrhage may potentially be surgical, in which case you'd want to consult with ophthalmology. When it's indirect, which just means the force of the bone has been transmitted to the optic canal and caused damage, there's unfortunately like no treatment we can do. It's just observation alone. We think that the mechanism of traumatic optic neuropathy may be due to several different things, but it's just like shearing force. Like if there was a quick, like if you hit the globe with something, like particularly like a projectile, there was a quick rotation of the eye that caused like sort of a shearing force of the optic nerve, or you could have swelling of the optic nerve as a result of the trauma that the optic nerve can expand where it's in close contact to the bony canal, like within the optic canal. So that may be another cause of traumatic optic neuropathy. In terms of the presentation, usually acute, so immediately following the trauma, there's vision loss present with an APD, but the disc usually looks normal, although it may be mildly swollen, depending on how anterior the optic nerve head damage is. You're going to start to see atrophy, pallor of the neural retinal rim tissue, NFL, GCC loss around 1 month following the trauma. Important to get a CT scan in cases of traumatic optic neuropathy to make sure there's no fracture or anything that you could potentially treat. And then treatment for indirect, usually nothing can be done. There are some studies that have been done and some case reports of high-dose steroids used trying to improve vision. However, they found in the study that it also increased mortality, so it's not commonly performed. And the prognosis is unfortunately usually poor. Remember our patient, he presented NLP, ended NLP. In traumatic optic neuropathy, the neurofibular and GCC loss can begin as early as 2 weeks post-trauma. It's really going to plateau at around like 20 weeks. And the pattern of loss is usually more diffuse as opposed to, like, if we think about our pattern of glaucomatous NFL loss, it's usually more vertically oriented, affecting the superior and inferior NFL, whereas traumatic optic neuropathy, it tends to be more diffuse. So if you're seeing a patient like long-term after trauma, and you're questioning, is this traumatic optic neuropathy? Is this glaucoma? The pattern of NFL loss may help you. The presence of neuroretinal rim pallor may also help you, because in glaucoma, we don't have pallor of the neuroretinal rim tissue, but in past traumatic optic neuropathy, we typically do. Right? And so just a review of our sort of little mini case series going through blunt trauma cases. Recall that acute manifestations of blunt trauma can involve subretinal hemorrhage, which may accompany a choroidal rupture, vitreous hemorrhage, choroidal rupture itself, macular hole, commotio retinae, retinal tears, retinal dialysis, detachment, rhegmatogenous retinal detachment, that is traumatic optic neuropathy. And long term, so important that you do gonioscopy at some point on this patient, probably not on day one of the trauma, right? But on some form of the follow-up where we're trying to see, is there angle recession and glaucoma? You can get pigmentary scarring. So a common cause of unilateral pigmentary changes is trauma, but also think about like maybe pachychoroid diseases in your differential list there, like central serous. And then when you have a choroidal rupture, certainly there's a risk for choroidal neovascularization to develop long-term. There was something else I should have put on here too, was hyphema. I'm not sure how I missed that. You can write that in. Any questions on that case? Right, moving on to sort of a neuro case. So the fifth diagnosis is the charm. And so this patient presented to multiple providers, like the ER, primary care, myself, before a proper diagnosis was made. And I'm willing to admit, like, the fourth misdiagnosis was mine in this particular case before we finally actually figured out what the problem was. But this is a 37-year-old female. She came to our optometry clinic, like in the outpatient clinic, as a walk-in because her primary care provider had just seen her that same day. They said, like, you have a red eye and some swelling of your eyelid. We think you have pink eye. Why don't you go see optometry? So she's coming in as like a potential like red eye assessment, conjunctivitis. She does have a red swollen eye and eyelid. This is the actual patient. So this is around the time of COVID. She's wearing a mask there. You can see there's, some mild diffuse injection of the bulbar conjunctiva. There's a little bit of edema, kind of swelling of the surrounding skin and periorbital region of the right eye there as well. So why they're thinking she has pink eye is because the eye, looks red and kind of injected there. She's also complaining of some right-sided radiating headache, periorbital and facial pain, like a burning sensation on the face, as well as some vertigo. It started when she woke up 3 days ago. And she said this happened the same time as this like pink eye issue. She said the vertigo is so bad that she's having trouble not falling over as she's walking. So she said she fell 3 times since this started 3 days ago. In terms of her medical history, I mean, she's 37, but she does have some high cholesterol. She actively smokes, some chronic migraine, as well as anxiety and depression. Her ocular history, we had done an eye exam on her 6 months ago, and everything was within normal limits. And she's denying any sort of trauma that occurred prior to this or these issues occurring. So to kind of dig deeper into the history and go through some of the initial diagnoses, when this first happened, remember, she said she woke up with all these symptoms 3 days ago. She said the first day it happened when she woke up, she went to the ER, they diagnosed her with neck spasm and gave her some muscle relaxers and sent her away. The second ER visit 3 days later, because she was just noticing, like, this isn't getting better, there has to be something else going on. The medication isn't working. They diagnosed her with migraine, gave her Toradol and Meclizine, and again sent her away. She immediately went from our ER, like crossed the street over to our outpatient health center and went to see her primary care provider and said, I keep being seen in the ER and they're not really addressing my complaints. I feel like there's something really seriously wrong with me. The PCP, I think they had done a CT scan or something. They said she had maxillary sinusitis and they gave her antibiotic augmented and then sent her to optometry because she has this pink eye issue. Right, so when she comes over to see us, her vision is, pretty good. So 20/20 in the right, 20/25 in the left. Entrance testing, unremarkable. Her IOP is slightly asymmetric and lower in the right eye, which I do think is related to the diagnosis in this case, the ocular diagnosis. So slight IOP lowering in the right eye that has this hyperemia and periorbital edema. But as we can see on her slit lamp examination, there was some diffuse injection of the bulbar conjunctiva, a little bit of injection and swelling of the periorbital region, and a little bit of a upper lid ptosis on the right eye as well. When we look at her pupil testing here and look at the pupils closely, her direct consensual and accommodative responses were brisk, so we know that the sphincter muscle is working. However, we have anisocoria present that's greater in dim illumination setting. So as we can see in dim, the right pupil is smaller compared to the left. And so when we have anisocoria greater in dim, it means that there's an issue with the dilator muscle of the iris in the smaller pupil eye. So we're thinking, could there be a loss of innervation, sympathetic innervation to the iris dilator in the right eye? We're thinking, is this potentially a Horner syndrome? We have anisocoria greater in dim. We also have a mild lid ptosis on that same side. So we have potentially multiple features consistent with a Horner syndrome. I think another pupillary feature that's important to look for in a Horner syndrome is what we call a dilation lag. So because we have decreased innervation to the dilator muscle, it takes a lot longer for the pupil to open up in a Horner syndrome when the lights are turned off or to dilate compared to the normal fellow eye. So if you do pupil measurements, like say at like 5 seconds versus 15 seconds into darkness when you hit the lights, you're gonna have the greatest degree of anisocoria at the 5-second mark compared to the 15-second mark. So when you're taking pupil photos or you're doing pupil measurement assessments, it's important to try to measure it as quickly as possible after you turn off the lights, because that's when the anisocoria is going to be most obvious in patients with Horner syndrome. So we see this dilation lag, this anisocoria. We're thinking, how can we confirm that there is a Horner syndrome present, which we suspect? What diagnostic drop testing is indicated? We did not have cocaine in office, so we did an aproclonidine test. So aproclonidine is the most commonly used diagnostic agent nowadays to confirm a Horner syndrome. It doesn't tell you where it is. It's not like a localizing thing. It just tells you, is it present or is it not present, a Horner syndrome? You could use 0.5% aproclonidine or 1% aproclonidine to do this test. You're going to put 1 drop in both eyes, and ideally you haven't touched the cornea yet in either way by doing like tenometry or anything like that. So you get equal absorption of the iopidine into both corneas and hitting the iris kind of equally. Typically you'd wait 30 minutes or 60 minutes after installation of iopidine. I typically will like check the pupils at 30 minutes. If it's positive, okay, like that's that. If at 30 minutes it still looks negative, I will wait the full 60 minutes or 1 hour, check it again to make sure it's still negative at that point. So in this patient, this is our like baseline pupil size where we had the right pupil being smaller. And then here, this is 30 minutes after iopidine installation in both eyes. And we can see that the right pupil is now a little bit larger compared to the left. So is this a positive test? You guys did a great job at this, right? So 100% people are saying yes, right? So if we have reversal of the anisocoria, meaning the smaller, what was once the smaller pupil is now the larger pupil compared to the fellow eye, that's considered a positive iopidine test for Horner syndrome. Remember, you can't do a localization test at the same day as a confirmatory test, like putting multiple drops in like hydroxyamphetamine. It's also hard to get commercially. And so Typically, once you confirm the Horner syndrome, I would then try to use the clinical clues to tailor your workup rather than doing like hydroxyamphetamine testing or anything like that. Just a quick review of Horner syndrome. Remember, there's this classic triad of ipsilateral ptosis, meiosis, and facial anhidrosis. Facial anhidrosis we don't typically test for clinically, but the ptosis and meiosis are things that we're going to see on clinical examination. Typically, the ptosis is very small, so about 1 to 2 millimeters. If you have the eyelid being completely down, that's not a Horner syndrome. Like there's something else going on there, right? And the ptosis is related to denervation of the Mueller's muscle or sympathetic innervation to the Mueller's muscle in the upper lid. We also have facial, or excuse me, I'm sorry, the meiosis is typically like, and the anisocoria degree is minor, so like less than 1 millimeter decrease in the diameter of the affected pupil. We're going to have this dilation lag present as well. But a really important point is that your pupillary direct, consensual, and accommodative responses are going to be normal, right? I see a lot of time, like students or residents think that, oh, it's a Horner syndrome, the pupil reaction should be sluggish. No, because the sphincter is still, it's under parasympathetic innervation, right? The sphincter is still working just fine, right? So your direct light response is going to be brisk. It's just an issue with the pupil dilating, not constricting. So I think that's an important point here to make. You don't need to have all three of these classic triad features present to make a diagnosis of Horner syndrome. Keep that in mind. Lesser acute signs. So this was definitely the most acute Horner syndrome I had ever seen in my career, unfortunately. So presumably by the time she presented, this was like 3 days old Horner syndrome. So some acute signs that can be present, which will eventually go away. Acute conjunctival hyperemia. Remember, she had some hyperemia of the bulbar conj that they thought it was a pink eye and sent her over to optometry. That's a common presentation of a very acute Horner syndrome. And decreased intraocular pressure. Remember, our patient's pressure was like 11 versus 15. So I do think that was pathologic in this case related to the Horner syndrome. When we think about the pathway of the sympathetic innervation going to the iris dilator, we know it's a 3-order neuron sort of arc. So the first order neuron going from the hypothalamus down to the ciliospinal column of Budge, the second order neuron going from the ciliospinal column of Budge over like through the chest and everything over to the superior cervical ganglion. And then the third order neuron going from the superior cervical ganglion via the long ciliary nerves to the iris dilator, as well as the Mueller muscle in the upper lid there. And so the most common neuron that's damaged in cases of Horner syndrome is second order. So this represents about 50% of Horner syndrome cases. So anything that could be going on like in the chest area, like a Pancoast tumor in smokers, etc., would be a second order neuron lesion. The most common cause of a first order neuron lesion is a lateral medullary stroke. So if we look at this first order neuron, it's going from the hypothalamus all the way down through the brainstem. So like potentially any issue in the brainstem, midbrain, pons, medulla, could result in a Horner syndrome, but usually it's a lateral medullary stroke at the level here. And then third order neuron disease, which is this blue one here, could be a consequence typically of either carotid or cavernous sinus disease. So remember the sympathetics here kind of hitch a ride on the internal carotid artery. So a carotid artery dissection can cause a painful acute onset Horner syndrome. You could also have in the cavernous sinus a Horner syndrome occur. However, not in the cavernous sinus, there's a bunch of other things in there too, like cranial nerve 3, cranial nerve 4, cranial nerve 6, right? So you probably have some other like motility issue or something going on with the Horner syndrome. If it is a cavernous sinus lesion, it's unlikely to get just an isolated Horner syndrome from a cavernous sinus disease. And then cluster headaches. In all cluster headache presentation, I think it's important that you roll out carotid artery dissection because it can be very difficult that the presentation of cluster headaches, because you have a headache in a Horner syndrome, which could be a very similar presentation to carotid artery dissection, which could be fatal, right? So in cases of cluster headaches, it's important to do some CT angiography imaging of like the head and neck and upper chest to rule out carotid artery dissection. So because this patient was complaining of like, like a headache, like retrobulbar sort of radiating pain, I thought that she had a carotid artery dissection, this, Horner syndrome that started 3 days ago. I called the ER and I sent her back over to the ER and I said, you need to do some CT and CT angiography imaging of the carotid arteries to rule out a dissection in this case. So carotid artery dissection, I just want to discuss that a little bit as a potential cause of a painful acute onset Horner syndrome. It is a significant cause of ischemic stroke in all age groups, and about 50% of patients with carotid artery dissection will have some sort of ocular sign or symptom as the presenting feature. In most cases, that is a painful Horner syndrome, about 44% of the time. About 30% of patients will have monocular transient vision loss. So as this hematoma is kind of forming in the dissected wall, it can break off little pieces that travel as emboli to the eye, causing transient monocular vision loss. These pieces that break off and travel to the eye could also travel to the brain and cause an ischemic stroke. And so that's the concern here, and why you need to refer these patients so urgently for anticoagulation therapy is because about 1/3 of patients presenting with transient vision loss will subsequently have a full-blown stroke or cerebral vascular accident within a mean of 5 to 6 days, so almost within 1 week of the first episode of transient vision loss. So we need to consider carotid artery dissection in every painful postganglionic Horner syndrome. Then I want to review some high-risk features of Horner syndrome that would necessitate workup in adults. So in acute onset Horner syndrome, I think you should always do an evaluation to try to identify a cause. If there's arm or shoulder pain, you're thinking this could potentially be a Pancoast tumor, especially if a patient smokes. If there's neck, head, or eye pain, we said that could potentially be carotid artery dissection. If there's transient vision loss or TIA-like symptoms, again, that's probably going to point towards potentially carotid artery dissection. If there's ocular ischemia, let's say essential retinal artery occlusion, branch retinal artery occlusion, and that's going to point towards potentially carotid artery dissection. If the patient has a history of malignancy or cancer, they could have a metastasis, anywhere along that 3-neuron arc that goes all throughout the body, right? That could be causing the Horner syndrome. So certainly you want to work that up pretty thoroughly. If there's a history of neck or head trauma, so carotid artery dissection can be spontaneous, but it can also occur following trauma. So that would be something that you would want to evaluate. Or if there's a history of smoking, again, you think this patient could potentially have a lung tumor or an a lung apex tumor called a Pancoast tumor. So concerned that this patient could potentially have carotid artery dissection. So I sent her back over to the ER, recommending a CT angiogram of the head, neck, and upper chest. So I'm trying to make sure we cover the entire pathway of the carotid artery there. And they did that. They said there was no dissection. Everything was completely normal. I'm not kind of left dumbfounded because I know for certain she has a Horner syndrome, right? That was present, started 3 days ago. They then did MRI imaging, which is a higher resolution way to image acute stroke, ischemic stroke, versus say a CT scan. And so on the MRI, they found that she had a stroke of the lateral medulla. So this was that first order neuron that was traveling through the brainstem was infarcted and therefore caused the Horner syndrome. And they felt that this lateral medulla stroke was actually due to a vertebral artery dissection. So the vertebral arteries are back here, that's more posterior circulation related. Unfortunately, now we're at 3 days, so she's outside the time window for potentially clot buster or TPA therapy that we would consider in acute stroke, ischemic stroke cases. They did put her on blood thinner to try to treat this vertebral artery dissection and prevent further strokes from occurring. Certainly controlling her vasculopathic risk factors, smoking cessation, and referred her to a physical therapist because of her vertigo. Remember, she was falling and things like that. So a lateral medullary stroke clinically causes a presentation with various signs and symptoms that's termed Wallenberg syndrome. So this could potentially cause ocular findings such as a Horner syndrome being most common, possibly a skew deviation, so vertical diplopia, nystagmus, defective saccades and pursuits. And then from a systemic perspective, it can cause vertigo, which our patient had. ipsilateral gait and limb ataxia. So that may have also contributed to why she was falling as she was trying to walk. Ipsilateral facial and corneal numbness. So remember, she said she had this like burning sensation on her face, which was related to, I think, this like innervation issue. And then contralateral loss of pain and temperature sensation of the body as well can occur. Any questions on that case? Are there any contraindications or precautions to using aproclonidine? It's a really interesting one because if you look at some of the like classic teachings. So I teach like neuro-ophthalmic disease at the school right now. So I've had the pleasure of kind of diving down into a lot of the standard of care documents and all those things. But say in children, like aproclonidine is generally contraindicated because it can cause like respiratory distress. So technically, like in children, you'd think cocaine wouldn't be safer, but somehow it is. So typically, like in a pediatric Horner syndrome, like a child under the age of 1, you should be using cocaine to do a Horner syndrome confirmation versus aproclonidine. I personally would not do this. I would be referring to some sort of ophthalmologist, like pediatric or neuro-ophthalmologist, to do cocaine testing in a young infant with Horner syndrome. Great. Moving on to our next case, which I've entitled Under Pressure. This was a 58-year-old male. He was sent from primary care because he had diabetes, and in our hospital setting, it's really nice that we have trouble keeping up with like just our diabetic eye care. It's like really tough because so many patients have diabetes, and we're in a rural area where there's just not a lot of eye care providers, and so they'll take like screening color fundus photographs in primary care to look for diabetic retinopathy. When they did this, whoever looked at it, this was phenomenal. This doctor like saved this patient's life. I'm so impressed. The primary care provider that like looked at the photo said there's disc edema, like not diabetic retinopathy, there's optic disc edema, and set the patient immediately same day down to optometry, which were just like 1 floor below primary care. So the patient literally was just up in primary care, got a photo taken, was concerned for disc edema, and sent down to us. He really didn't have complaints coming in, but when we further like questioned him about signs and symptoms related to papilledema, because he had bilateral disc edema, presumably from this photo, he did say he had maybe like a pressure sensation around the eyes, was seeing some halos, had a slight headache for the past 2 to 3 days, like a swishing sound in his ears. Again, this wasn't anything he volunteered. This was after we like pointedly asked him, do you have these symptoms? His medical history is remarkable for hypertension, diabetes, high cholesterol, some hearing loss. He's on some medications related to that. Of note, no medications that have been known to cause papilledema, such as like tetracycline antibiotics, or Accutane, or high-dose vitamin A. In terms of his examination findings, his visual acuity is 20/20 in both the right and left eye. Pupil testing is normal. IOP is like kind of a little bit on the higher end. His blood pressure, which is so important that you check in patients with bilateral disc edema, right, was within normal limits at 144/88. His hemoglobin A1C, we have like medical records that are open access to everybody in the hospital. So we can see the patient's last A1C was 9%. A little bit poorly controlled. However, he doesn't have any diabetic retinopathy. This is like the ultra wide field photograph of the right eye that we took. This wasn't the one they took in primary care. This was ours. And you can see that, generally the fundus looks unremarkable. But when we look at the optic nerve heads, and this was such a good catch, right? This is like really subtle early disc edema that they sent down from primary care, where it seems to be predominantly the superior and inferior aspects of the disc margin are a little bit swollen. When you're suspecting it could potentially be papilledema, really important that you look for a spontaneous venous pulsation. If you see a spontaneous venous pulse, it means that papilledema is unlikely. So we would look ideally right where the vein is coming out of the optic nerve, so like right here, or potentially right here, or right here, and we did not see a spontaneous venous pulse. Here's the left eye. So this swelling is a little bit more severe. And the pattern of swelling in papilledema follows the isn't roll. And we're familiar with the isn't roll in terms of like glaucomatous thinning and that, right? But if we look at think about why the inferior rim swells the earliest and the most, it's because it's the thickest to begin with, right? So it has the most potential to swell. So typically in papilledema, you'll see the inferior rim swell, then the superior rim, then the nasal rim, and then temporal is usually spared unless it's really, really severe disc edema, right? So our patient's pattern of like swelling matches what could definitely be papilledema. He also has here like some telangiectasias or kind of hyperemia on the disc surface, which is also kind of suggestive of papilledema because you have like congestion of the optic nerve head, which can cause some superficial capillary dilation present. This is the nerve fiber layer OCT that we took. You can see the neuroretinal rim is kind of diffusely, mildly thick in both eyes. And then we have nerve fiber layer swelling predominantly superior and inferior, which we said is a pattern characteristic of early papilledema. This asymmetry between the left and right eye in the inferior nerve fiber layer swelling too, I think is really indicative of true pathology as opposed to, him just physiologically having thick nerve fiber layer or something. I'm sorry, I just want to see if there's a question that came in there. Having trouble keeping up. So on fundus autofluorescence, we did take this just to rule out any sort of like disc drusen or anything. And on fundus autofluorescence, you see there's no disc drusen present. I do FAF on all patients with like disc edema. So on B-scan, and so B-scan kind of kills multiple birds with one stone in terms of your papilledema assessment. So it helps you roll out disc drusen, like buried disc drusen. So fundus autofluorescence is a great way to pick up superficial disc drusen that's kind of like close to the surface. But buried disc drusen, the gold standard of diagnosis is still B-scan ultrasound. So on B-scan, we're looking for disc drusen buried down in there. We didn't see any. We also want to look at the fluid in the subarachnoid space. So remember in true papilledema, where there's increased intracranial pressure, you have excess fluid in the subarachnoid space around the brain, but that's also continuous with the subarachnoid space around the optic nerve. And so as we look at the optic nerve here, this is the subarachnoid space, and fluid is dark here on our ultrasound scan. So we can see there's increased like fluid cuff around the optic nerve head that's potentially indicative of true papilledema. And some studies will show that like if you measure what we call the optic nerve sheath diameter, which is just like the thickness of the nerve as well as this cuff of subarachnoid fluid, 3 millimeters behind the papilla. So we went 3 millimeters back, then measured the optic nerve head sheath. Greater than 5 millimeters in terms of the sheath measurement is potentially suspicious for papilledema. Of course, the resolution of B-scan imaging isn't that great. So I would kind of like take this with a grain of salt and put it in a clinical context, along with like other tests that you have going on in your examination. But I want to kind of make some correlates between our multimodal imaging modalities, right? So we can understand like why we're seeing what we're seeing. So if we have increased fluid in the subarachnoid space on B-scan, we said that would look like this dark cuff of fluid here. On T2 weighted MRI, a finding of true papilledema, again, is increased fluid in the subarachnoid sheath surrounding the optic nerve head. And T2 MRI on the T2 fluid is bright. So this bright area right here is fluid in the subarachnoid space. So imagine on B-scan, what is dark fluid is light fluid on T2 weighted MRI. So we're kind of making correlations between those two imaging modalities. In papilledema too, when it's like really severe, you can have so much fluid in the subarachnoid space that it causes on MRI what they call like flattening of the posterior globe, right? So you can kind of see it's like indented here, the posterior globe. On OCT, we have upward angling of Bruch's membrane. So you kind of see that subarachnoid fluid back here is pushing the Bruch's membrane forward and causing this upward angling. So this upward angling feature on OCT, you can correlate with this posterior flattening of the globe on MRI imaging in true papilledema. Again, kind of drawing a correlation now, looking at like an coronal cut through the optic nerve head, as opposed to this was like an axial cut. So on a coronal cut, remember T2 weighted MRI, the fluid is still bright. We have this like donut ring of increased fluid in the subarachnoid space. So this circular bright area is increased fluid consistent with papilledema in this case. right? If we look on B-scan, you get what this like crescent sign is called. If you're doing your B-scan at such an angle that you're like cross-sectioning through the optic nerve head. And the reason we get that crescent sign is because, again, of that fluid in the subarachnoid space. And it's very similar in presentation to this like ring of fluid on coronal T2 MRI imaging. Patton's lines or folds are a sign of true disc edema as opposed to, say, pseudopapilledema from disc drusen or just physiologic small crowded nerves or whatever. So the ability to identify true Patton's lines or folds is really powerful in saying, is this true disc swelling? A way that you can try to detect really, really early Patton's folds is to use in-FOS OCT imaging. So remember, we took like an optic nerve head OCTQ to look at the nerve fiber layer, but then you can also do your in-FOS analysis. Look at this VR is like vitreoretinal interface. So in terms of our boundaries, we're looking at the very superficial aspect of the retina there, where we have these like peripapillary wrinkles or Patton's folds. These wrinkles always occur on the temporal aspect of the optic nerve head first in early papilledema. In this particular case, when we looked at it clinically, we couldn't see the Patton's folds, but this is the actual patient's in-FOS OCT. We're able to pick up these early Patton folds, knowing that this is definitely true disc edema. Here are just some other examples of patients of mine that had more severe papilledema present, where we're able to see these Patton's lines or folds on in-FOS OCT. And kind of correlating with these like undulations or peripapillary wrinkles in around the level of like the NFL internal limiting memory. So our diagnosis for this patient was indeed, from an eye exam standpoint, definitely looks like he has true papilledema, despite the lack of any real like severe systemic complaints of papilledema. Like, he had some mild headaches, maybe some squishing in his ears, like pulsatile tinnitus. Didn't have any transient vision loss, no nausea or vomiting or anything like that. Your first step in papilledema assessment, we'll check the blood pressure, make sure the blood pressure is not like out the roof, muddling in hypertension level. And then you're going to start with imaging. So MRI, MRV of the head, and then going on to do a lumbar puncture if that is unremarkable. And your lumbar puncture should include both CSF analysis as well as opening pressure measurement, right? We think that this patient likely has some sort of true pathology causing the papilledema, that it's not idiopathic intracranial hypertension because he's male, number one. So he just doesn't fall into like the demographic of like idiopathic intracranial hypertension. We need to look for a pathologic cause. I always, and I think we're going to see the value in this case, order MRV along with MRI when I do my initial evaluation of papilledema in all patients, to look for dural venous sinus thrombosis that can cause papilledema. So we, same day immediately, it's seen all places of us, right? So he went from primary care to optometry. He now goes over to the ER the same day to get his MRI, MRV done. This is his MRI, and the radiologist is reading this within normal limits. But then the MRV showed that he had a massive, extensive dural venous sinus thrombosis, with the MRI being normal, right? So if all I did was order an MRI, we would have missed this. Right? But the MRV is picking up this massive thrombosis of the right transverse sinus, sigmoid sinus, and internal jugular vein. So you can kind of see these veins on the unaffected side and hear how we don't have visualization of any sort of venous blood on the right side of the like lower brain there. If we think about it, right, if you have a thrombosis in the venous system, it causes like increased venous pressure so that the subarachnoid fluid can't like freely just drain into those venous cavities, and you end up with increased intracranial pressure. So our diagnosis is papilledema secondary to dural venous sinus thrombosis. They in the ER then initiated a very large workup for this patient to try to figure out like why this happened. Did he have some sort of blood dyscrasia, like a hypercoagulable state? They did a lot of blood work on him, didn't find anything. They did some cardiovascular evaluation that came back normal. They then looked at the veins in his extremities because they were concerned if he has this thrombosis in his brain, he could have like deep vein thrombosis in his legs and stuff too. So they did imaging of his legs and all that came back okay. Your typical treatment for dural venous sinus thrombosis is going to be heavy anticoagulation. So they started him on Levinox and then also prescribed oral apixaban for him to take long-term for this dural venous sinus thrombosis. So papilledema can be caused by so many different things, and I think going through this list is outside the scope of this lecture, but make sure you consider a lot of different etiologies in terms of papilledema. A dural venous sinus thrombosis, we said, is an obstruction or a thrombosis that occurs in the cerebral venous sinuses, which is where CSF typically drains into or is absorbed. And that's the mechanism of why we get increased intracranial pressure and papilledema in cases of dural venous sinus thrombosis. It could be related to hypercoagulable states, or in our patient's case, it was just sort of like spontaneous or idiopathic. We didn't really have a reason that we ever identified why it occurred. The presentation is similar to idiopathic intracranial hypertension in terms of the symptoms, signs, but it usually develops more rapidly than true IIH. And this is an emergency due to the risk of stroke related to the dural venous sinus thrombosis. The real take-home of this case is you see papilledema, don't just order MRI, also please order the MRV component to look for potential dural venous sinus thrombosis. We know that dural venous sinus thrombosis represents about 1% of all strokes, especially younger patients under the age of 50. There is an 8% mortality rate associated with dural venous sinus thrombosis, and typically the treatment is anticoagulation. Right, let me see if there's any questions related to that case. Oh, could you repeat your answer for the aproclonidine contraindications in the Horner syndrome case? So in the Horner syndrome case, or aproclonidine should be avoided in like pediatric or infantile, I probably should say, like patients under the age of 1, because aproclonidine can cause like respiratory depression. So typically the literature would recommend that you do cocaine testing to confirm a Horner syndrome in the pediatric population, like under the age of like 1 or 2, I think. I personally would not do that in office. I would refer to our friendly neighborhood ophthalmologist or neuro-ophthalmologist to do that, rather than put cocaine in a child myself. Great. And moving on to, this is probably going to be our last case. I'm entitled A Grave Prognosis. This is a 52-year-old female. She was actually coming in just for a routine diabetes examination, so she didn't really have any complaints. In terms of her medical history, she has type 2 diabetes for 12 years, not very well controlled with an A1C of 8.6%, hypertension, heart disease, kidney disease, high cholesterol, sleep apnea, as well as COPD because she's been a long-term smoker and still currently is. Her vision is 20/20 in both eyes, entrance testing, pretty much all unremarkable there. We do blood pressure on any patient that we intend to dilate in our facility. So the first time we measured the blood pressure was 187 over 118. The second time we measured it was 189 over 112. At that point, I then ask a patient, have you taken your blood pressure medications today? Are you compliant with your medications? Prior to potentially sending them somewhere to lower the blood pressure. Because if they have the medication on them, like in their purse, I'm just going to take it and then check the blood pressure again later. But she said she's been compliant with all of her 6 prescribed hypertensive medications, and still the blood pressure is this high. So anytime you're measuring a systolic pressure of 180 or above, or a diastolic pressure of 120 or above, it's at least a hypertensive crisis or urgency. You then say, is this an emergency? So an emergency would be, is there the presence of new or worsening end organ damage? So headaches, chest pain, indicative of potentially like a heart attack, or papilledema, like malignant hypertension. So we know we need to address this blood pressure situation. We did not dilate her, we just took like fundus photos looking. And so on the fundus photos, these are undilated again. We can see that there is some disc edema. This was present in both eyes. The veins are kind of dilated and tortuous. There's a reduced AV ratio with like generalized arterial attenuation, an increased arterial light reflex, which would be suggestive of hypertensive retinopathy. Then she has some hemorrhaging, right? So we have some dot plot hemorrhaging. We also have some flame-shaped hemorrhaging. So it's likely a combination, the hemorrhaging is a combination of diabetic and hypertensive retinopathy. The left eye looks quite similar. However, the disc edema isn't quite as bad, and we also have a cotton wool spot that's grossly present here, in addition to some intraretinal hemorrhaging, these dilated tortuous veins, etc. And so, any other questions you want to ask here? So with the blood pressure being so high, we want to ask about signs and symptoms related to end organ damage. So blood in the urine, like worsening chest pain, shortness of breath, headache, etc. The fact that we have papilledema in and of itself is end organ damage. So when you have, again, like a blood pressure measure greater than 180/120 associated with end organ damage, this is a hypertensive emergency. So we contacted her primary care. Again, this was just like one floor up, told her what we were seeing. We suspected she had stage 4 hypertensive retinopathy or disc edema related to her very high blood pressure, in addition to some, background NPDR. They said they'd see the patient, so I wouldn't let a patient like that walk themselves, like put them in a wheelchair and take them up to get the blood pressure lowered. They lowered her blood pressure in office. In hindsight, I probably would have handled this a little bit differently. So I think doing like a CT scan that day would have probably been appropriate, because when the blood pressure is that high, you risk having an intracranial hemorrhage or like a hemorrhagic stroke that a CT scan would pick up. And so I think that probably should have been done in this particular case. And then probably should have seen the patient sooner back than just like 1 month. But she does come back 1 month later for follow-up. She said since the last time she was here, she's been having headaches daily that last most of the day. Her vision is now starting to be slightly reduced, even with pinhole in the left eye to 20/25. Her blood pressure, again, is just way too high, so 182/91. She's admittedly saying she didn't take her blood pressure medications because she's feeling sick and her blood pressure bottomed out way too low yesterday. Her fundus appearance in terms of the disc edema is unchanged. Again, because of this blood pressure measure like being over 180, and we're still seeing disc edema. This is her OCT from that 1 month follow-up. We recommend that she go back upstairs for IOP, or IOP, for blood pressure lowering, but the patient refused. We're able, with our open access medical records, to kind of follow up and see like what ended up happening with this patient. So I could see that 1 month after that visit, she came into the ER complaining of abdominal pain. The diagnosis of that visit was acute kidney injury, chronic kidney disease, stage 6. I tried to look this up, and I don't see a stage 6. It's only it goes up to stage 5. So it was like really, really severe kidney disease. It's like basically no kidney function whatsoever. Due to cardiorenal syndrome and poor oral intake, they offered her hemodialysis. She declined. She was discharged on hospice and then ended up dying 10 days later. And this is me now kind of going on a rant to show you another case of like really severe hypertensive retinopathy, stage 4 hypertensive retinopathy that presented to our residents. So this was a 47-year-old female who they asked the resident to come evaluate the patient in the ICU. The reason being is that she had a hemorrhagic stroke, so an intracranial hemorrhage. She said that she like bent over to pick something up off the floor of her kitchen, and all she remembered was just like waking up. So she bent over, like passed out. When they admitted her, so she called the ER or 911 when she woke up. They transferred her to the ER. On admission, her blood pressure was 197/141. They did find in her urine screening that she had amphetamine, so that probably contributed to the blood pressure being so high, I would guess. But the reason they're asking us to come over and see the patient is she has decreased vision in the left eye and is complaining of some vertical double vision. This is the handheld fundus camera photos in the ICU of this patient. You can see it looks like there's probably some macular edema. We have this like classic exudate star associated with some disc edema bilaterally in both eyes. And look at the severe attenuation of the arterioles, right? Suggestive of really severe hypertensive retinopathy in this patient. Her vision in the left eye was 2100, I think, as a reduction or a consequence of this macular edema from hypertensive retinopathy. Let's skip over some of this in the interest of time. So systemic hypertension, we know, affects nearly half of adults in the United States, is only controlled in about 50% of patients. It is the single most important modifiable risk factor for stroke. So remember that second patient I showed you that was in the ICU because she had a hemorrhagic stroke due to the blood pressure being so high. but it's also a risk factor for both hemorrhagic and ischemic strokes. And the presence of retinopathy is a strong predictor of stroke, with the risk of stroke being 2 to 3 times higher in individuals with retinopathy compared to those that don't have hypertensive retinopathy. It is the fourth largest mortality risk factor in the world. We know that adequate control of hypertension can decrease the incidence of heart attack, as well as stroke and heart failure. We think about the classification of systemic hypertension, with a normal reading being less than 120 over 80, and then pre-hypertension being a systolic reading of like 120 to 129, and then systolic or diastolic being less than 80. And then we have our high blood pressure stages. So stage 1 would be a systolic reading of 130 to 139, diastolic reading 80 to 89. Stage 2 would be a systolic reading of 140 or greater, diastolic reading of 90 or above. And then we have, and what I've highlighted here, which I think is important for us as eye care providers to know, when does it require immediate attention? Is this an urgency or an emergency? So if you have a reading systolic 180 or above, or diastolic 120 or above, it's at least a crisis or an urgency that requires immediate attention or like lowering, right? What determines whether it's an urgency or an emergency is the presence of new or worsening end organ damage. So if you see stage 4 hypertensive retinopathy and papilledema, certainly that is a hypertensive emergency. You have ocular end organ damage. A headache, altered mental status, signs of stroke, transient ischemic attack symptoms, chest pain, like heart attack symptoms, shortness of breath, all those things would be concerning for a hypertensive emergency with a reading that's this high. And then just a brief review of hypertensive retinopathy grading. So this is the Keith Wagner-Barker scale or classification. There are a lot of different ones out there, but they're all pretty similar. So stage 1 or group 1 hypertensive retinopathy, we have a reduced AV ratio that's caused by just generalized arterial constriction. So an AV ratio like less than 2/3, maybe the AV ratio is like 1/2. Stage 2 would be you have, say, like little focal constrictions of the arteries, or you have AV nicking. Group 3 or stage 3 hypertensive retinopathy, you now have hemorrhaging, which is usually flame-shaped hemorrhaging intraretinally, exudates, cottonwool spots. And then stage 4 hypertensive retinopathy being like all of those findings in addition to like bilateral disc edema or papilledema. And with that, I will conclude. I get to the end slides here that I know we need to get to. If you have any additional questions I haven't had a chance to get to here, please feel free to email me at major@nsuok.edu.
Thank you, Dr. Major. That was great. Those were some interesting cases, some really crazy things that you just never expect are going to walk into your clinic, I'm sure. Let's see. Now, if there are, you did such a great job managing the questions. I don't see any currently. So as we wind down, if there's any other questions that may have come up, there's some great comments in there thanking you for your wonderful presentation. If there are any last minute questions, feel free to put those in. If not, Dr. Major has kindly shared her email address. So if you think of something after we finish, you can always email her there. As we get that QR code up, I just wanted to thank everybody for taking the time to spend with us this weekend. I know 8 hours of CE in 2 days is a daunting task, but it was very, very well done. Thank you to all the presenters who were here and spent their time with WooU. Thank you to each and every one of you for taking either a day or two to spend with us, and we really appreciate it. So we will not be returning at 10 a.m. That was old. So we're done for the day. So make sure you scan that QR code now. And with that, I will wrap up and let everybody get on to their day and to enjoy the rest of their Sunday afternoon. And we will see you at the next WooU University event. Thank you, Dr. Major, for being here. And thank you all for joining, and we'll see you soon. Thank you.